Side.
No specific side, no specific position other than side.
Okay.
So you can have right lateral, left lateral. It's just side.
Side.
Sims is much more specific. So Sims is a lateral position.
Right.
It's just that it's a very specific modified lateral position. So Sims is going to be lying on the left side with the right knee up, bent, and the arm up. And what this does is it elongates the colon. So if we're going to do anything involving the rectal area, like a suppository or an enema or a scope or something like that, the Sims position is what we want to be in, just because it elongates that colon. Okay. Go ahead and throw that back up, Jay.
Oh, no, it was an
okay.
technical difficulties.
All right.
The microphone wasn't registering while you were taking it.
Oh, okay.
I got it fixed.
Thank you. Yeah, this is why I need you. Good morning. All right, so this is our final review, guys. This is it. I won't review with you on Monday or Wednesday of next week. So if you want to review before you go take your test, the first 30 minutes of class 6 is your best bet, because we're going to review pretty much everything we've gone over so far. Now, I am going to go through this very quickly, though, because we've got a lot to cover today. So this is just a comprehensive review of everything we've learned so far. How do we know what to do with each patient? Care plan. We're going to follow the care plan, the whole care plan, and
Nothing but the care plan.
what does that mean?
The whole care plan.
Yeah, don't change it.
Yeah. Don't add anything.
Don't add, don't change.
Don't subtract. Don't think.
Don't divide. Don't multiply.
Yeah, don't think. Just follow. Very good. While we're performing the tasks on the care plan, we should be observing for abnormalities. And that means anything you see or hear or feel or smell, anything that just makes you stop and go, what do we do with those observations?
Report them to the nurse.
Report them to the nurse. Do we make decisions based on those observations?
No.
Okay, good. All right. So every skill is going to start with an opening. What does every opening start with? A knock. Once we've knocked, we don't have to wait for a come in for the test, because it's considered kind of an open door type thing for the test. So you don't have to wait for them to acknowledge you or say come in or anything like that. You just knock to let the patient know that you're invading their space. Once you enter the room, you have to greet the resident. And how do we identify them?
By name.
By name. So for the test, everybody's going to be Mr. or Mrs. Jones. What do they need to know about you?
Our role.
Okay, your name and your title. Yeah, your role. Very good. So just walking in and say, hey, I'm Patty. That's not enough. I'm Patty, your CNA today. And you should do that every time you walk into a patient's room. This is something I didn't cover, but it really is kind of the height of arrogance to believe that a patient who is sleep deprived, self-focused, in a strange place, surrounded by strange people, and they've only met you once or twice, to remember who you are, especially when you're dressed like everybody else. That really is kind of the height of arrogance to assume your patient will remember you. They probably won't. They may remember that you have some role to play with them, but take that expectation off of them. Every time you walk in the room, hey, it's Patty, your CNA today. Hey, Patty, CNA, I'm back. You want to make sure that you're not overly burdening them with an expectation that they may not be able to meet. Good? Make sense? All right. Once they know our name and title, what else do we need to tell them? Yeah. Why are we there? What skill are we there to do? And then we have to get something from them. What do we need?
Permission.
Yeah. Consent, permission. Absolutely. Don't touch somebody without their permission. After we get all that done, we can close the curtain and then go wash our hands. Remember, you cannot touch the patient until you have clean hands. You also can't touch your supplies until you have clean hands. So now that we've gotten all of that done, and we're talking about supplies, we're going to evaluate if we need gloves. And we need to know for every skill whether we need gloves. Okay. So this isn't really based on the skill, it's based on the patient we're doing the skill on. If the patient has any body fluids or non-intact skin, or you're going to be touching personal skin. Yeah, if any of those apply, then we need gloves. So let's say that I'm going to go in and, I don't know, put EKG tabs on a female patient, okay? And she has no undergarments on. So I'm going to be working around her breasts. Now, she has no body fluids. She has no non-intact skin, but do I need gloves?
Yes.
Why?
Personal skin.
Personal skin, that's right. So this is more for their comfort, right? We are strangers. We should not be in personal areas without an extra layer of protection for them. Does that make sense? Yeah. All right. So if we do decide that we need gloves for this particular skill, what's first thing they should touch?
The patient.
Should I touch my supply? Should I put them on to get my supplies?
No.
Should I put them on to put toothpaste on the toothbrush?
No.
So the first thing they should touch is the patient. So do all of your prep work first, then get your gloves on. Guys, when you're practicing, that's going to be the hardest step for you because everybody wants to put their gloves on too early. It's just kind of ingrained in us. The problem with that is everything you touch with those gloves
Was contaminated.
will potentially contaminate them and bring that contamination right to the patient. So try to remember the first thing your gloves should touch is the patient. Now, once your gloves are soiled, you know, you touch the patient, you've done the skill, whatever, pay attention to what you're touching in the environment with those gloves. Don't touch the curtain. Don't give them the call light with their gloves. Try to minimize that contamination. And then we have to know how to remove gloves correctly. So to remove gloves correctly, skin can touch skin, glove can touch glove, but skin can't touch glove. So we're going to pinch up on one hand, pull that off, and then go underneath on the other hand and pull that off. Good? All right. So if we decide that we do need supplies for whatever reason, we have to have a place to put those supplies. Supplies are clean. So we need a clean place. Table is not. So what can we use?
Barrier.
A barrier. And the whole purpose of a barrier is just to give us a clean place for those clean supplies. And we only want to touch the supplies with what kind of hands?
Clean.
Clean hands. When you're getting your supplies, what can't those supplies touch?
The uniform.
Your uniform, it's not considered clean. So we want to go get the barrier and put it on the table and then go get our supplies and put those on the barrier. Good? Good. All right. One of the supplies that we might need for a skill is a privacy blanket. How do we know when we should use a privacy blanket? If the patient is cold, uncovered, or undressed. Yeah, or cold is fine, but uncovered or undressed is what we need to be looking for. So if I'm going to take this person's sheet away for any reason, I need to give them a privacy blanket. Fair? Fair? All right, so if we decide that we're going to use a privacy blanket, how should we put it on? Should we snap it or should we unfold it?
Unfold it.
Unfold it. So we're going to unfold it over the sheet and pull that sheet down underneath so the patient remains covered at all times with something. And then at the end of the skill, when do we remove the privacy blanket? Before or after we take our gloves off? After we take our gloves off. Very good. Very good. Another supply that we may need are linens. If we decide that we need linens for a washing skill or some other reason, there's some rules that have to go along with them. The linens cannot touch your uniform. Yep. What kind of hands do you need to get those linens?
Clean.
Clean hands. And what do we not want to do with linens?
Set them on the
Okay,
floor.
so they can't ever go on the floor, not clean or dirty. Nothing ever goes on the floor. We also can't snap or shake them. Clean rolls, which way? Clean rolls
Towards you.
Towards you.
Dirty
Dirty
rolls
rolls
away.
away. Very good. Very good. And what happens if we take too many supplies and we don't use them all? What do we
Still
do?
goes to the
Still
dirty.
goes to the
Still goes into dirty. You don't leave them in the room till later. So now that we've gotten all those supplies taken care of, let's talk about the patient. Where does the patient need to be in the bed at all times?
middle.
The middle.
In the middle of the bed. Can we use side rails to keep them safe if we're doing a skill?
No.
No, because you're not going to have side rails in all settings. That means the patient needs to be in the middle of the side rail for safety without the use of side rails. Okay, good. How do we do that? How do we put somebody in the middle of the bed if we're going to turn them on their side?
Scoot them.
Scoot and roll.
Scoot them towards you and then roll them away from you. Remember that you always have to remain behind the patient's behind, right? We're always turning them away from us. So take a look at the patient to make sure they're in the middle of the bed. Now, I'm going to tell you that this, at the end of every skill, so we're going to get to the closing in a minute, but at the end of every skill, we're just so happy that the skill is over. We tend to rush through that closing, right? We've gotten all the hard stuff out of the way. Just get through that closing, and you tend to rush. I want that closing to be the longest part of your skill. You will rush it. I want it to be the longest part of the skill because if you are rushing, you don't stop to look at the patient. And for the test, what is the skill all about? What is the test all about?
The patient.
The patient. So if you're at the end of the skill, you've done whatever insert skill here, I don't care which one, and you're at the end and you're like, okay, here's your call light. I'm going to open the curtain. Your environment's clean. Bed's in the low position. Can I get you anything else? You're good. All right. Open the curtain. Go wash my hands. I really didn't look at that patient. Right now, I'm concentrating on myself and getting those check marks to get done with the skill. And what ends up happening is this patient will be like that, okay, for whatever reason. But you're not going to pick it up. You're not going to register it because you're so busy focusing on the tasks that you're forgetting to look at the patient. So at the end of every, is this safe?
No.
Because the patient's not
In the middle.
in the middle of the bed. So if it doesn't register with you, if you don't walk by this and think, oh my gosh, something is wrong, and you don't acknowledge that, it will impact your score. But more importantly, it's going to impact the patient in a real life setting. So the closing, the best advice I can give you, and it really has everything to do with this. Patients have to be in the middle of the bed. The evaluators are looking for this. They are looking. When you're doing your closing, they're looking to see, is the patient in the middle of the bed? So take a minute, slow yourself down, and make sure that you're looking at that patient. You're not just trying to rush through the steps. Okay, good. Good. This is especially important in sideline position. Remember how we turned the patient over, right? One arm up, over, knee bent, knee angled, and then we turned them, put pillows behind the back, between the legs, under the upper arm, and adjust one of the head. Well, if you look at that patient and they're not in the middle of the bed, you need to do something about it. Don't think, well, that's good enough. It's not. Because you can do that whole skill, do it all absolutely beautifully, but at the end of the skill, if your patient is too close to the edge of the bed, none of that mattered. None of it. So again, make sure you're looking at that patient. They need to be in the middle of the bed. This is a non-negotiable. I think this is probably one of the most important principles that we have because it deals with safety. And yet, it's something that we just tend to like get through. Remember, this one's important. We have lots of washing skills. We've learned several already, and we're going to learn another one today. Washing skills require us to wash a certain body part. How do we know which body part we're supposed to wash?
The care plan.
The care plan. So if the care plan tells you to wash one leg, what are you going to wash?
One leg.
That's it. You follow that care plan religiously. Now, I've given you the care plans for the state exam, but understand that they can change those care plans. They can change those care plans. So the best advice I can give you is to make sure that you are reading the care plans. Now, they have to give us notice. So if they change the care plans, I'll let you guys know. But remember that in a clinical setting, these care plans are based on the patient. So I don't want you to get overly dependent on the testing care plans. I want you to get used to reading a care plan. And side note here, I give you guys the testing care plans, and that's relatively new. I didn't used to do that. I did not give students the testing care plans. And the reason I didn't do that for many years is because you guys get overly dependent on those testing care plans. I mean, you start to memorize it because, we've got the cards and they're in your book and, you're focused on those care plans and you start, memorizing the care plans because you've got a test coming up and you're preparing for the test. I did not give testing care plans for the longest time because I want you to get used to reading the care plan, not memorizing what's on the test. So please remember that. These are used as a guide for the test. But no care plan out there is going to be exactly the same. All right, so if we are going to wash something, if we have to wash a body part, do we put soap in the basin?
No.
Why?
You use it for rinsing.
You got to have clean water for rinsing. Absolutely. So no soap in the basin. Do we put soap directly on the patient's skin?
No.
Well, where does the soap go then?
Washcloth.
So we're going to wet the washcloth and then put soap on the washcloth. Make sure you wring that washcloth out really well. No drippy wet washcloths. Okay. If we're going to get water for washing, if we need water, can we touch the faucet on the sink
No.
with our bare hands? What do we need?
Paper towel.
A paper towel. Now, time out there real quick. There are some instructors, and I understand why they do this. There are some instructors that teach their students, whatever you touch the faucet, use a paper towel. And that's okay. That's perfectly okay for you to do. We know that faucet's dirty. You can touch it with a paper towel anytime. Nobody cares. Okay. So if you're stressing this, just use a paper towel every time you touch the faucet. Nothing wrong with it. I want you to have a little bit more awareness of clean versus dirty. Guys, if I took these shortcuts, it would make it so much easier on me. I would have to talk so much less, but it wouldn't make you a good CNA, capable of critical thinking. Okay. So yes, you can use a paper towel every time you touch the faucet, but you have to use one in this specific scenario. Because your hands are clean, you wash them, you went and got your clean supplies, and you cannot touch that faucet to get water with clean hands. So you need a paper towel. Good? Good. What should the water feel like?
Warm.
Warm. Not hot, not cold, just warm. But just because you think it's good, does that mean the patient's going to agree?
No.
So how do we know?
Ask the patient.
Ask the patient every time. Every time. All right. If we're going to wash any wet body openings like eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions, we need a special washing process that we learned last class. This is called the leaves method. And this allows us to use each corner of the washcloth once and then fold it in a certain way to give us a clean area to work with. So remember, we use the leaves method for any body openings. Okay. Whatever we wash, whatever we rinse, we dry. If that water gets cold or soapy because you're taking a long time to do this skill, what should you do? Yeah, change the water. Get some new water. Absolutely. As we're washing things, you want to take special care not to get your surfaces wet, whether it's the table, the floor, the bed, whatever you're working on. And then if we put lotion on, what do we have to do before we put lotion on? Warm it. What do we do after? Wipe it off. Now, let me talk to you really briefly about the lotion thing. I'm going to pull up a chair today because my knee hurts. Yeah. Okay. Latchman. Hello, Miss Patty. Good morning. I can breathe. I passed my CNA exam. Oh, congratulations. Hold on. Congratulations to you, Latchman. Great job. Very good. Okay. So let me talk to you a little bit about that lotion. If you noticed in the partial bed bath video that we watched last class, and that was the video, because I have all of the checkpoints on that video on the bottom of the screen. And if you noticed, when it comes to lotion, the checkpoint wants us to warm the lotion, but it says by rubbing it together in our hands or putting the bottle in the bath basin to warm it up. So either way is fine on the state exam, as long as that lotion is warm. But let me tell you why I want you to warm it up in your hands. Because when you have a bottle of lotion and you put it in the warm, remember that water isn't hot, it's just warm. You put that bottle in the water. First of all, we don't know how clean that bottle is. Okay, so now we're getting stuff in our water that we're going to use on the patient's face. Probably not the greatest idea. But the real problem is that if that water does penetrate, it's only going to get the very outside edge of the lotion warm. And when we squeeze the lotion, we're squeezing it from the middle. So that heat is not going to penetrate. So even if you put the bottle of lotion in a basin, it's not going to be as warm as the patient needs it to be. So you're still going to have to rub it up, rub it in your hands. So that's why I don't teach you to put it in the basin, because it's just not as effective. And there's an infection control process there that I'm just not real thrilled about. That doesn't mean it's wrong. And I bring that up because I just had a student that tested about 2 months ago and said, but Miss Patty, the person that I was testing with put the water in the or put the bottle in the water in the basin. Was that wrong? Because she passed. Was that wrong? So I explained that to her. So I need you to understand it's not wrong. It's just probably not the best practice. Good? Questions? All right. And then if we wash something, we have a basin that's going to need to be cleaned. And we're going to clean every basin the same way, whether it's a bath basin or an emesis basin or a graduate container, which we'll use on Monday, or, whatever or a bedpan, whatever we're using has to be cleaned the same way. And for the exam, we simply rinse it, dry it, and store it. There's no special process here. Just rinse it out, dry it out, and store it. Don't put feces or urine in the sink. That's all they care about, right? That's it. No feces or urine, and that just makes sense. Rinse it, dry it, store it. I want you to use this method because if you do have to disinfect, you've got to know how to do that. I mean, how do you disinfect? So this process allows you to disinfect. But for the test, rinse, dry, store. Shoe rules. If the patient's feet hit the floor, we talk about their shoes. slipper socks are not enough, guys. And I know that we see it in a clinical setting all the time. And if you go to a nurse and say, hey, that person doesn't have shoes on, the nurse may give you a blank look like, so? This is one of those things that you don't know until you know. Make sense? You don't know. I mean, you didn't know that. You didn't think about walking around a clinical setting in slipper socks and then getting back into bed with those slipper socks. You really didn't think about it before we talked about it. Your nurse may not either. So just a very simple explanation like pathogens on the floor back in bed with the patient. And they'll go, oh, I didn't think about it like that. Good point. So just a little explanation really is all you need there. But please, if the patient's going to be walking around, make sure that they have something firm on their feet, because if they step on something, it can cause injury. And especially if the patient is diabetic, they may not be aware of that injury, and that can cause long-term problems. Okay. If for some reason they don't have anything hard, either put shoe covers over those socks or change out those socks when they get back into bed. But don't bring those pathogens into bed with the patient. That's just really gross. And then we have the closing. The closing is the closing. It's at the end of every single skill we do. So we're going to thank our patient because that's the reason we have a job. No patients, no jobs. So thank you very much, Ms. Jones. Is there anything else I can get for you today? Now, let me explain to you why I do this, and I am religious about this. I am absolutely religious about this. I do not leave this patient until I have covered every possible thing that they may want in the next hour, because I know that I'm going into another room, and that person needs my full attention, just like this person got my full attention. And if this person is on the call light every 5 minutes, that one's not going to get my attention. So I make sure that this person during my closing has everything covered. Are you comfortable? Is there anything I can get for you while I'm here? A blanket, sweater, TV remote, you good? Magazine? Snack? How's your water? I'm going to cover it all because I want them to feel well cared for before I leave. And that buys me time to do the same thing with the next one. If you're in a hurry to get out of that room, they're going to sense it. And those are the people that generally tend to need more attention. Okay. So I'm religious about my closing. I do it with everybody, no matter what. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Everything good? Okay. Bed's in the low position. Environment is clean. Here's your call light. I'm going to go open the curtain. Now, after I've done all of that, I have to go wash my hands because I need to leave the patient's cooties behind to go to another patient. So I'm going to go wash my hands. If I have to document, I'll do that after I wash my hands. And then I'll wash my hands again. Because when we leave this patient, we have to do it with clean hands. Good. You never know what's waiting for you in the hallway. You just don't know. It could be a patient that fell and is bleeding. Or it could be a family member with some fresh donuts. You need clean hands for both. Good? Make sense? I prefer the donuts. All right. We learned how to take a pulse. A pulse is simply a measurement of how many times the heart beat over 1 minute. Normal is between 60 and 100. What finger can you not use to take a pulse? Thumb. Where is a radial pulse located? At the wrist, at the top of the wrist by the thumb. Not the bottom of the wrist, the top of the wrist by the thumb. once you've taken the pulse, make sure the arm is supported while you're taking the pulse. After you've taken the pulse, what do you need to make sure that you do with that number? Document it, write it down. Very good. Very good. In Florida, you may have to count with 2 evaluators for this skill. They'll let you know. We learned how to dress a resident with a weak arm. The way we do this is USA first. Undress strong arm first. Dress weak arm first. We're going to let the patient choose their own clothing. We're going to make sure that we minimize exposure as much as possible with privacy curtain, making sure they cover the privacy blanket, just preserving modesty as much as possible. Support all extremities while we lift them from below with a flat palm. Make sure those fingers are together when we're putting the sleeves over so they don't get bent backwards. Don't overextend or force movement. We'll adjust the clothing so that they look good and all dirty items go in the hamper. Where does the call light go for this skill? Stronger hand. Very good. Hand and nail care. The mini mani. You're going to soak one hand, wash one hand, rinse one hand, dry one hand. We'll clean under the nails with an orange stick. Which side should we use? Pointy or slanted? Slanted. And what should we do between nails with that orange stick? Wipe it on the towel. Very good. We're going to file any rough edges with an emery board in one direction toward the middle. Do we use nail clippers? No. If you file the nails on a regular basis, you never have to use nail clippers. That's the whole purpose here. We're going to put some lotion on. What do we do before we put the lotion on? And what do we do after? Wipe it off. Do you put lotion on first or last? Yeah, I don't even know why that's a checkpoint. All right, making an occupied bed. We're just simply going to change a sheet a half at a time. So get the patient on their side in the middle of the bed. We'll take the dirty sheet and roll it toward the patient because dirty rolls away. We'll take a clean sheet and attach it to the mattress and roll it towards you because the clean rolls toward me. And then you get the patient on their back, go around to the other side of the bed and do it all again. Put the top sheet on. Make hospital corners. We don't care how pretty they are. Just get the corners off the floor. Remember, nothing touches the floor. And then we're going to loosen it over the toes. Pillowcase goes on the pillow with the opening facing away from the door. That's kind of routine, but that's not a graded checkpoint. Try to limit the amount of time that they're without the pillow, though. Don't take the pillow away first, change the sheets, and then put the pillow back in last. I mean, you don't want that whole skill to be without a pillow. Limit the time there without the pillow. Okay? Good.
I have one question. That came up in the chat a few minutes ago.
Okay.
I'll put that up for you. I feel that would apply. Here we go. Here we go.
Okay, creative fam. I passed my CNA, both clinicals and written, last month. Congratulations. I am trying to get a job and I'm really scared of nursing home. What is your advice for a new CNA? Okay. Hang out for about 10 minutes and I'm going to go over a resource for you that's going to help you kind of figure out where you belong. Okay, so give me about 10 minutes. Let me finish this and I'll be happy to go over that. Okay, so side lying position. This is when we're going to turn somebody on their side and use some pillows to keep them in place. So the furthest arm goes up, closest arm crosses the chest, closest knee is bent, furthest knee is angled out. And then you just roll them. Do you roll them towards you or away from you? Away from you. We're going to put a pillow in a roll behind the back. We're going to put one in between the legs, specifically between the knees and ankles, so they're not rubbing together. One under that top arm and adjust the pillow under the head. The call light should go in the bottom hand for this skill. Foot care, just like hand and nail care, a little lower and nothing with the nails. So we're simply going to soak the foot, take it out to wash, put it back in the rinse, take it out to dry. Every time it's out of the basin, it should be on a towel. Apply some lotion. Look at all surfaces. That's why you're there, is to look. Put the sock back on, remove the wrinkles, put the shoe back on, and fasten it appropriately. That's the skill. Mouth care. Brush your teeth. It's not a hard skill. What position do they need to be in, though? Sitting up, fully upright. That's right. So we're not just going to put the head of the bed up. We're going to put the pillow behind their back to get them in that upright position. They're probably going to get toothpaste all over them. So what can we do to cover their clothing? Towel, sure. We'll wet the toothbrush before we put toothpaste on, and you brush. Whatever they got, just brush it. Nobody cares how long it takes. Nobody's looking at that. Brush what they've got. Then we're going to let them rinse and spit as much as they need to. And then we're going to clean up. Don't leave them a drippy, wet mess. Make sure that you dry their face. And it's crazy that so many students forget that. So many students will leave the patient sitting there dripping. So again, we should be taking the time to look at the patient. Are you starting to see that? Up until now, you've been focused on the steps. So we're at the point now that you should kind of have an idea of how these steps are going, so we can take a step back and start looking at the patient while we're doing these steps. Good? Good. All right. We also learned respiration. This is breathing in and out, counts as 1. Normal is between 12 and 20. We are allowed to use the alcohol pad on the tummy trick for the test. You can use that, no problem. We are not going to tell the patient that we're counting their breathing. Make this look like you're taking the pulse. This is a documentation skill. So at the end of the skill, you're going to have to document and then wash your hands again. Good morning. Range of motion. We've learned 3 range of motions. We learned range of motion of the shoulder. Oh, I took your chair. Sorry. You can also sit over there if you want.
That's fine, whatever y'all want to do, don't matter.
Sure. Hold on a second.
Put this over?
Just set it, yeah. Set it down. There we go. All right, so we've learned 3 range of motions. We've learned range of motion shoulder, range of motion elbow and wrist, and range of motion hip, knee, and ankle.
Oh, okay, I can get in that spot.
Range of motion, hip, knee, and ankle. So each range of motion follows the same pattern. We're going to read the care plan. It's going to tell us what body part, what exercises, and how many repetitions. And we're just going to follow that. If it says right elbow and wrist, then we're going to exercise we just follow the plan that's laid out before us. That's it. Flexion extension is up, down. This is flexion extension. Abduction, adduction is a side to side motion. Rotation is an around motion. You just do whatever the care plan says. Remember, a range of motion has to be a full range of motion. So we go all the way back down to start. So wherever you start is where you end. Okay. Denture care, just like mouth care with an extra step. So with denture care, we're going to clean the dentures at the sink and clean the mouth those dentures came out of. So when we're cleaning the dentures, we want to use cool water. You want to make sure you're keeping the dentures over the sink. Don't set them down in the sink. You'll use the denture brush with toothpaste. Wet the denture brush first, put toothpaste on, and brush all surfaces of the denture, rinsing it, being careful not to drop it. Put it in a clean, that cup filled with clean water, put the lid on and a paper towel underneath. And then go brush the teeth like we did mouth care. It's a little bit longer skill, but it's just mouth care with an extra step. And we learned how to ambulate with a gait belt last class. This is simply walking the patient. Super easy. When we put the gait belt on, it goes around the patient's waist, over their clothing, and gets secured tight enough that we can only fit 4 fingers between the belt and the patient. We're going to stand at that oblique angle, 1 foot in front of their feet, 1 foot beside the chair, making sure that they have shoes on and those shoes are flat on the floor. Help the patient stand. Let them stand for a couple seconds to acclimate, and then walk as far as care plan tells you to. Before you stand that patient up, make sure you look to ensure that your pathway is clear. Return them back to the chair. Help them sit. Remove the gait belt without pulling it against the skin, and do your closing. That, to me, is probably one of the easier skills. Super quick, 5 minutes. Partial bed bath. We learned this last class as well. We're going to use that leaves method because we're washing a wet body opening. We're washing the eyes, the nose, and the mouth. So we'll use that leaves method. All of our washing rules apply here. But for the test, this care plan is going to tell you to wash from face to waist, front and back. 1 arm and hand. Should we wash the other one too while we're there for extra credit? No, care plan says 1 arm and hand. That's all we're doing. The whole reason for that, guys, is they're trying to shorten the skill. It's already at 19 minutes. They're trying to make it shorter for you. Where do those evaluators want to be? At home in their pools drinking their margaritas. If they watch you wash 1 arm, they don't need to see it on the other side. What they had talked about doing at one point is telling you to wash half of the torso. So basically just wash like the right half, front and back. That was very confusing to students. They just, where do I stop? Is it the top half, bottom half? It was just way too confusing. So they went back to wash the chest, abdomen, side, 1 arm and hand and back. It's all just a time-saving thing. So how do I put this? Don't rush, but don't be super slow at this either.
So how about like the audience for women, the breast part?
So when we wash the breasts, you're going to wash the breasts. But when you lift, we don't lift with the palm of our hand. We lift with the back of our hand.
No, I'm not saying like for the patient. I'm talking about for the test. Are they going to be able to wipe?
So for the test, this is a mannequin skill.
Okay.
So we're not going to do it on another live person. So we're not, exposing anybody.
Right.
That's a very, uncomfortable thing for everybody involved. Yeah. No eye contact after that, I'm sure. So, so this is going to be a mannequin skill. The good thing about it being a mannequin skill is that she's plastic. So things kind of stay where they're supposed to stay. In a clinical setting with real people, when you're lifting the breast, make sure you're lifting with the back of your hand. For the back part, they'll reach over and hold them. Yeah.
So should we do back first or chest first?
Do the front, turn them over, and then do the back.
Okay.
Yeah. And the evaluator will be standing there. You shouldn't have to ask them to hold the mannequin, but if they're kind of daydreaming or whatever, you can ask. Can you please hold the mannequin? But they should do that on their own. All right. So any questions? Look how much you guys have learned. That was a long review. That was a lot of stuff to go over. Think about how much you guys have learned. You've only got 2 classes left after today. We're almost done. Has it been hard? You guys feel like you're pretty prepared? You know what to expect on the exam? Okay. So let's talk about what Joy had asked. we have a resource for you. Jake, can you put the workplace quiz up for me? We have a resource for you to help you figure out where the best place for you to work is. This is a question I get asked a lot. Where should I start applying? Because you're now at the point that you're starting to think about work. Where do you want to work? And before I get into this, how many of you guys think that you might want to work in a hospital? Okay, pretty common. How many of you guys want home care? Okay. Assisted living facility. Okay. Nursing home. Pediatrics. Mental health. Rehabs. There's a lot of places we can work. It's not just all about hospital. Although that's what a lot of people think when they start thinking about CNA. That's where a lot of people kind of have the idea they want to be. But that's not always the best choice, because your personality is going to play into this. Different places are going to have different workflows. Let me give you a good example. I am a high energy person. If you give me repetitive tasks, I'm going to zone out on you. I'm just not that person. I have to be constantly challenged. So if you put me in a home care situation with one patient, I am going to go out of my mind, because there is not enough there to keep me busy. I need stimulation, right? It's just kind of my ADHD type mindset. I've got to be going all the time. I got to have problems to solve. So for me, working in the ICU was ideal because I never ran out of problems. It was a great experience for me. I've also worked in a doctor's office. I did that for about 5 years when my kids were all little. I loved that, not because I liked what I did. It was very boring. It was very routine. I did the same thing every day. Put the patients in the room, take their vital signs, find out why they're here. Put the patient in the room, take their vital signs, find out why they're here. Put the patient in the room, take their vital signs, find out why they're here. Very monotonous for me.
For CNA, that's all you have to do?
Pretty much, yeah. So for me, it was kind of monotonous, but I loved the job because I had small kids, small children, and I didn't have to work nights and weekends and holidays, and that was ideal. That was awesome. I've always had a home care job in my back pocket that I would see, patients here and there when I needed extra money for a cell phone bill or a light bill or Christmas is coming or whatever. So there's different things that are going to meet different needs. But I am a high mental energy person. Now, my oldest son does not do change at all. When I used to change my hairstyle, he would cry for a week. My mother had to volunteer at school when he went to kindergarten because he wouldn't stop crying. Okay, and these are all true. He does not do change. So if he goes to work at a hospital, he is going to be out of his mind in a few hours, because in a hospital, it is nothing but change. We have admissions and we have discharges. We have care plans that change by the hour because your patients get better and worse that quickly. We get test results. It is nothing but change. It's a fast-paced environment. So if you are not on top of your skills, this is not the place to try to learn. You've got to have strong skills. Otherwise, your coworkers are going to be giving you the side eye and probably talking behind your back because you're too slow. So do you see how that your personality can play into this?
Mm-hmm.
Right? You have to figure out what kind of a person are you? What do you like? What do you not like? What kind of care do you want to provide? Are you the type of person that wants to really spoil somebody and give them all of your attention? Well, home care or a small assisted living facility might be the best choice for you. If you're the type of person that doesn't really want to get to know your patients very well, you just want to treat them and go, then maybe a walk-in clinic might be a good option for you. You have to think about personal care. Are you comfortable giving personal care, brushing teeth and giving baths and helping patients with those types of things? Or do you prefer more of the technical side of things? Because if you're looking for more technical, then the hospital and certain units and rehabs might be right up your alley. But if you are wanting to concentrate more on the personal care, well, then assisted living or nursing homes might be a better fit. So you have to look at the whole thing, not just where do I want to work. You got to figure out what's going to work for you as well. Otherwise, when you get into work, you're going to be absolutely miserable and you'll end up leaving healthcare. If personal care isn't for you, mental health might be. If you don't really want to deal with old people, pediatrics might be your thing. If you want to have time to spend with the patient and the families, hospice might be something worth looking into. So you have to kind of do a little bit of digging to figure out what's going to work best for you. Luckily, I've done all this work for you. If you go to, can you put it back up for me? Thanks. If you go to, and this is in your email as well. If you go to, personality quiz. So 4YourCNA.com, your ideal workplace. If you go here, it's a 19-question quiz that I made. It's going to ask you all kinds of different personality type questions. And then it's going to tell you one of 9 places that might work best for you. And it tells you why. So if it says, hey, the hospital might be your place, and this is why: fast-paced environment, team dynamics, so you're working closely with the team, good benefits, opportunity for advancement. It goes through every aspect of what makes a hospital a good environment for you based on your answers. Okay, good. Now, it took me 2 years to develop this quiz. I am not exaggerating. It took me, there's a huge amount of psychology in this quiz, but I tried to make the questions short so that it's not overwhelming for you. I tried this out on hundreds of current healthcare workers, and it's scary accurate. It is scary accurate. People that have been in healthcare for a long time took this and said, it pegged me. It's accurate. So if you take the quiz and you get nursing home and you're like, oh, I don't want to work in a nursing home. It's not for me. It's not what I wanted. Understand that it may actually be what you want. You just don't know it yet. So don't shy away from giving it a try. You can always quit. There's no penalty for that. Good? Good. Okay, thanks. You can take that down. All right.
So assisted livings also do, they hire CNAs, because the one that I work at, they don't hire CNAs due to the fact that it's just changing them and getting them up and stuff like that. But there are ones that do hire for CNA.
Sure, and a lot of assisted living facilities, even though you don't have to be a CNA to work there,
Yeah.
they usually will give you a little bump in pay once you get certified.
Yeah.
So that's something that you'd want to kind of talk to your employer about.
They totally disclose any CNAs from working in the building. because they can't afford it. It's
Okay.
$15 an hour flat rate, and med techs make $15 an hour, period. too.
Yeah.
So that's what I was saying, because I like the assisted living. My grandma lives in a nursing home, and I don't like the
The
hospital,
setting.
the hospital
hospital
vibes of it. I can't do a hospital. I'm too slow for that.
I live home.
Yeah, everybody's a little bit
I
different.
worked in a nursing home and for home health, and I've worked it so long, I don't. it's
Looking
not
for
my cup of-
something new.
Yeah, it's
Yep.
not my cup of tea anymore. I've done it for so long. It's good to start out though as a home health aide, to get
Sure.
your foot in the door. Because when
Sure.
I first took the class, yeah, I learned a lot from it.
Very good. Yep. Everybody's going to have a different solution to that problem. And it'll probably change as you go through your career as well.
So how about like mother baby unit for CNA?
Yeah, I had a question. That was a good question.
Are we gonna apply for something?
Yeah, can we apply for something like that? Because I see jobs for it
If-
as a CNA.
Sure. I mean, you can apply for, if once you're a CNA, you can apply for any opening that is looking for a CNA. So here's the thing about mother baby units. Occasionally you will see CNAs positions advertised for mother baby, but it's actually not that common.
Right, I've never.
Yeah, it's
Not
not
in my area.
not that common. So we have to think about, right? CNAs are nursing assistants. So CNAs can work wherever a nurse works. If there's a nurse, they probably need an assistant. Good? Makes sense? Okay. So wherever a nurse works, a CNA can work. So you can work in dialysis. There's nurses in dialysis, and they hire what they call you dialysis techs, but you guys are qualified. So let me kind of explain. I call it the alphabet soup, and this is one of those things that just makes me want to pull my hair out because it's so complex and so hard to explain. So I'm going to really try to simplify this for you. There are only two places that you need to be certified to work, that you actually have to be a CNA to work at. One of those is nursing homes. In order to work in a nursing home, you have to be a CNA. Okay? In order to work in a nursing home, you have to be a CNA. The other is home care if you don't have a home health aide. So in a nursing home, you have to have your CNA. In home care, you can have a home health aide or a C. You have to have something because you're not being supervised. But you don't have to be a CNA to work at the hospital. You don't have to be a CNA to work in dialysis. You don't have to be a CNA to work in a walk-in clinic. You don't have to be a CNA to work in a doctor's office. You don't have to be a CNA to work in assisted living. Right? Those are all other. Now, most of those settings do want you trained, though. They would prefer not to train you. And if you're a CNA, well, you know normal versus abnormal. You know what needs to be reported. You know how to take vital signs. You're ahead of the curve. We like you. Come on in. But they probably aren't going to call you a CNA because they don't need CNAs. You don't have to be certified. Remember, C is for certified. So they probably are going to call you something else, like a rehab tech or a nurse tech or a mental health tech or dialysis tech or insert name here, PCA, PCT. All of those do the same job. They just have different titles. The only ones that require certification, the actual CNA, would be nursing homes or home care if you don't have something else. Make sense? Everybody good? So when you're looking at these opportunities at the hospital, they may not say CNA. They may say nurse tech. They might say PCT or PCA. You guys are all qualified for all of those jobs without anything extra. They just aren't going to call you CNA because they don't need a CNA in that position. Good.
Mhm.
So when you're looking for a job, this kind of opens up but now it makes it harder to figure out what to search for because there's so many possible terms. A lot of times, in order to simplify this on the employer standpoint, they will just offer a job for CNAs because they know if you're a CNA, you meet this criteria. So even though they don't need a CNA in that position, you don't need to be certified. They may advertise it as a CNA position just to get you guys to apply. But then once you start working there, they call you something else. Make sense? Good. Okay. So when you're looking for a job, look for CNA jobs, but you also look for PCT, PCA, rehab tech, nurse tech, and so on and so forth. But let's talk about specialty departments in a hospital like the mother baby unit or ICU or neuro ICU or there's a million different departments. Each one of those is going to require a very specialized skill set that's different from what you've learned in here. In a mother baby unit, you're not going to be brushing anybody's teeth. Right? Mother baby units, these are women that are giving birth. They can brush their own teeth. Babies have no teeth. You're not brushing those. So different skill set. But because it is a specialized area, a lot of times they won't hire brand new CNAs because you don't even have the basics down yet, much less specialized skills. Does that make sense?
So would you have to, okay, say if you wanted to be like, baby mother unit, would you have to already have like a, training for that?
There is no formal training. There's no course you can take to become a mother baby CNA. So let me get to the other side of this, okay?
Mm-hmm.
So not only do you need training, but most of these places don't have routine care. Mother baby does, but it's still very, very highly specialized because there's a lot that can go wrong in the first 24 hours postpartum. And when it goes wrong, it goes very, 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 very wrong. We need people there that can catch it early so we can get the problem solved before it becomes a bigger problem. So most places aren't going to have CNAs in these units. We want nurses in these units. Now, that doesn't mean that they don't hire. I mean, you can still pass water. You can still, set up for baths. I mean, there's still things you can do, but your skills are better served in other departments.
Right.
Does that make sense? This is why you don't see a lot of opportunities for CNAs in specialized departments like ICU. Again, I'd rather have a nurse in that position rather than a CNA. So yes, you will see them occasionally, but not very often. Does that make sense?
Mm-hmm.
But I've had graduates. Well, I had one of the graduates out of my class many years ago. She was determined to be in the ICU. She got a job at the hospital. She made friends. She told the supervisor of the ICU, "Hey, I really, really, really want to work in the ICU," and she just kind of worked her network until a position was created for her, and then she was working in the ICU as a CNA. So I'm not going to say it can't happen. It can, but it's not as common. Remember, CNAs do routine tasks on stable patients. Right. Make sense? Good. Okay. Any other questions on that? Okay. Remember, alphabet soup. You are going to be known by a lot of different terms. All right, so let's learn transferring a patient out of bed and into a wheelchair. Do you guys remember Ambulate? This is a lot of Ambulate. I mean, a lot of the things that we learned for Ambulate is going to be involved in this particular skill. So if you look down the side, you can see the principles involved. They're all spelled out there at the bottom. Test-specific information is at the very bottom there. Somebody with your level of experience should be able to transfer somebody out of bed and into a wheelchair in 11 minutes or less. I can do it in 3. It does not take 11 minutes to do this. It's going to take me more than that to teach it, but it doesn't take 11 minutes to do it. If you look at top page 73, you can see the care plan. The care plan tells us the patient will be lying in bed for this skill. We're going to transfer the patient out of bed and into the wheelchair using a gait belt or transfer belt. After the transfer, they will remain in the room. So let me ask you guys this. If you were going to remain in a room, would you want to be facing a wall? No. You want to be facing something you can look at, the TV, a window, the door, something. So at the end of this skill, please make sure that your patient is not left facing the wall. That's just kind of rude. All right. So let's remember shoe rules. Remember when your patient's feet hit the floor, we have to talk about their shoes. Well, in this case, your patient is laying in bed. They're not going to have shoes on. So we're going to have them sitting on the edge of the bed, and then we have to stop and put shoes on. For the test, they are going to match you up with somebody your body size or smaller, whenever possible. And they're going to look for somebody that has slip-on shoes to make it quicker. So you don't tie your shoes, right? So you would be a great patient for that. Those are Hey Dudes, right? Yeah. Those are a little hard to get on over the heel. So I probably wouldn't use you. I would definitely use you. You got Crocs on. Those are awesome. So when you're being checked in, that evaluator is actually going to kind of look you up and down. They take in all kinds of stuff about you that you don't even know they're taking in.
We can wear Crocs.
Depends on the facility.
It's closed too, right?
Depends on the facility because every facility has a dress code. So you'd want to go by the dress code for that facility. For the test, you can.
Oh.
Closed-toed shoes, yeah. Yep.
Crocs for the test.
You can.
That was my question. The Crocs.
Yeah. All right, so we're going to get the patient sitting on the side of the bed, and we're going to put those shoes on, making sure their feet are flat on the floor and the shoes fit appropriately. We have to put the shoes on before we transfer them. That just makes sense. A couple of years ago, there was a school, I don't know which school it was, but this just drove me crazy. They started teaching their students to put the shoes on while the patient was still laying in bed. Don't do that. I mean, not unless you're planning on changing those sheets right away. Shoes don't belong in bed. That's just a pathogen nightmare. Slipper socks are not enough. We already know that. We're going to put a gait belt on around their waist. It should be snug, 4 fingers. They're going to put their hands on your shoulders. You're going to grab the back of the gait belt, and you're going to lift just like we did. That same stance, 1 foot in front, 1 foot beside. All of that is exactly the same. Making sure they have shoes on, feet are flat on the floor, gait belt is on appropriately. Have them put their hands on your shoulders, lift into a standing position. All of that is exactly the same. What's different is that we're not walking anywhere because this care plan tells us the patient can stand with support but cannot take steps. So we're not walking anywhere. Care plan says they can't take steps. We're not walking. So we're going to stand up and we're going to pivot that patient. We're literally going to turn them. And then we're going to help them sit in the chair. Okay. Good? Make sense? So we stand, pivot, sit. But if you remember with ambulate, I said that they had to feel that chair behind them before we asked them to sit. This is no different. They have to feel that chair. So what I don't want to do is pick somebody up, pivot them around, and have to hold them while I ask them, can you feel the chair behind you? Because that's way too long for me to hold somebody. So while they're sitting, before we ever lift them, while they're sitting on the bed, I'm going to tell them, I'm going to lift you to a standing position and spin you around. When you feel that wheelchair behind your knees, I want you to say, sit. Okay? Now, put your hands on my shoulders. I'm going to grab the back of the gait belt. We're going to lift on the count of 3. When you feel that chair, say sit. 1, 2, 3, up, over. He says sit. You sit. Good. It's a way of speeding the skill up where you're not holding their body weight. Any questions? All right. So we have to verbally state that the patient's feet are flat on the floor. We're going to count to 3 before we lift them. We're going to stand at that same oblique angle for stability, holding the gait belt around the side or back. Before we sit the patient in the wheelchair, we're going to make sure they can feel that wheelchair behind them. And remember, they are unable to walk or take steps. The evaluators are looking for this. If that wheelchair is not close enough to the bed and your patient has to take a step, it's going to affect your grade because the patient can't. So do you see how far away that wheelchair is from the patient? If I stand that patient up, are they going to be able to sit in that wheelchair without taking a step?
No.
So when you're putting the wheelchair next to the patient, it's got to almost touch the patient. I should basically be able to fit a sheet of paper between the patient and the wheelchair and nothing else. It's got to be that close. This is the number one error that's made on the state exam is the wheelchair is too far away. Once we get the wheelchair in place, we're going to lock the brakes. You've got to have the wheelchair locked to be able to put somebody in it. Otherwise, it's going to roll away from you. So locking the brakes. You can see there the yellow. See how that first picture, there's a gap? That means it's unlocked. Second picture, there's no gap. The metal bites into the wheel. Dave, will you please go get the wheelchair for me, please? Thank you.
Do you ever straighten your hair still?
When I'm not feeling lazy. Yeah, on my videos, I've straightened my hair, but it takes a long time.
That looks really good though.
It does look.
It's so funny. I never had curls before. Just the last 5 years, my hair got curly. It makes doing it a whole lot easier because I just scrunch and go. But I didn't have these curls before 5 years ago. I don't know what happened. All right. Wheelchairs are kept in the folded position for storage. To open a wheelchair, we're going to pull up on the handles and open the wheelchair, just like that. To close a wheelchair, you pull up on the center, put it back together. The brakes are going to be located in front of the big wheels, right here. That's good. Zoom in on the brake for me. Beautiful. Okay, so this is the brake. You can see here that there's a gap between this metal and the wheel. If I pull back on this lever, that metal bites into the wheel. That is now locked. To unlock it, I would push that lever forward, and now I have a gap. You guys see that? Okay. Both wheels have brakes. And it's important if we're going to put anybody into the wheelchair or take anybody out of the wheelchair, the brakes have to be engaged. Good? Okay. All right, you can go ahead and come back out if you would. And down. There we go. All right, so wheelchairs are a little bit higher than other chairs. We're going to talk about that in a minute. And they also, in addition to wheels, they have these leg rests and foot pedals. So leg rests have little catches on the back here that allow them to be swung out. And foot pedals just fold up and down. So when it comes to a wheelchair, we have the big wheels, we have the small wheels. We have brakes, leg rests, and foot pedals. And then, of course, you have the seat. So these are the parts of the wheelchair. Here. Anytime that wheelchair is not in motion, the brakes should be applied. When you're looking down this hallway, this floor looks level, doesn't it? It's actually not. There are areas of this floor that are wavy. Now, that's because it's concrete, and concrete settles and shifts, especially in Florida on sand. Up north, we have a lot of wooden floors that can warp with the temperature and humidity variances. So we can't rely on floors to be level. If we have a person in this chair, body weight in this chair, and the floor is not level and the brakes are not locked, this can start to roll. And it basically, whatever the patient runs into is what's going to stop it. That's a problem. So all wheelchairs have to be locked, and this is why. One of the biggest lawsuits in Florida happened in 2004. And this is, to me, this is absolutely tragic. There was a series of failures here. It wasn't one thing. It was a series of failures. But a dementia patient was strapped into a wheelchair. That's a restraint, guys. We can't do that. They put a dementia patient in a wheelchair, but they did not lock the wheelchair. And she was able to get herself into a stairwell. And because she was strapped in the wheelchair, that wheelchair tumbled down a flight of concrete steps. And the patient ultimately lost her life. So the first lesson here is we do not use gait belts as a restraint. We do not tie patients to wheelchairs ever, because in an emergency they can't save themselves. You also have to make sure the wheelchair is locked at all times. If that wheelchair had been locked, this wouldn't have happened. And then third, this patient should never, in a dementia unit, have had access to a stairwell, because that is unsafe. So we have to start thinking, I mean, these are all individually small details that might be overlooked, but let's think about this from the family's point of view for a moment. Why do families put patients in facilities, especially dementia patients? Why do they put patients in facilities?
To get the care they need.
Okay, yeah, they can't take care of them properly. They, you know, this is a 24-hour thing when you have a dementia patient.
They need extra help.
Absolutely. So if that patient can't be cared for by their family and they're placing that patient into a facility, it is mainly for safety reasons. Did we keep this patient safe?
No.
So ultimately we failed. And this is sad. This is sad. And what's really sad is I know this family was thinking to themselves, I should have just kept mom at home. She would have been safer here. That's not really the impression that we want to leave with patients and families, that they can do our job better. Good? Makes sense? All right. Wheelchair brakes are not a restraint. If this patient can go on their own. If I'm sitting in this wheelchair, you lock it on me, not a big deal. I can unlock it, go anywhere I want to. I'm an able-bodied individual with a sound mind. And if my wheelchair starts to roll into something, I'll be able to stop it. Wheelchairs, brakes are not restraints. If somebody is able to disengage them, they can go wherever they want to. The whole point is if they're not able to, they can't stop an injury from happening. Make sense? All right. Those that are unable to control a wheelchair, either because of physical or cognitive issues, require the staff to keep them safe. So all wheelchairs need to be locked unless they're actively in motion. But this brings us to another problem. And this is our problem. This chair, do you see how the chair seat is lower than the wheelchair? You guys see that? And we could do the same thing here. If I brought any of these chairs up, you'd see that the seat is a little bit lower than a wheelchair. And the whole purpose is because wheelchairs make the patient mobile. That's the whole point of a wheelchair. If I'm just going to have you sit somewhere, I'm just going to put you in a chair. If I'm going to take you somewhere, that chair has to have wheels. Make sense? Mm-hmm. All right. So why do we care here? Well, if I'm going to take you somewhere, if that's the end goal, I can't have your feet flat on the floor because your feet are going to impede my ability to take you somewhere. So the wheelchair has to be a little higher. Now that means that your feet on purpose are not going to touch the floor. Why do I care? This is why I care. Because running down the backs of your legs are arteries and veins. Arteries are bringing blood down to your feet. Veins are bringing blood back to your heart. Now, these arteries and veins get very close to the surface behind the knees. And when we sit, those areas behind the knees get compressed by the edge of the seat. If our feet are dangling, those blood vessels get crimped off. Now this will lead to swelling, but it also can lead to blood clots. Do you guys remember me saying last class that when blood slows down or stops, it clots? Do you guys remember that? This is what happens inside the veins. Inside your vein, you've got these little valves. And think of your veins as like ladders. When the heart beats, it's pushing blood up against gravity back to your heart. So when the blood beats, or when the heart beats, this blood in this chamber gets pushed up here, and then these valves close to keep it there. And this is how blood climbs back up to your heart. Well, if we've squished these blood vessels closed, that blood isn't moving anywhere. Blood that slows down or stops clots. So what is this patient at risk of? Blood clots. You can't just put somebody in a wheelchair knowing that the seat is higher and let their feet dangle. We have to have the feet on foot pedals, supported. That relieves the pressure along the back side of those knees. So if you're putting a patient into a wheelchair and you can't find those leg rests and foot pedals, don't just leave them in that wheelchair with their legs dangling. That's dangerous for the patient. You've got to find those foot rests. So 2 parts here. This that attaches to the wheelchair is called a leg rest. This part that the patient's feet sit on is the foot pedal. Foot pedals fold up and down, leg rests swing in and out. So when it comes to wheelchairs, when it's in use, this is what it should look like. Leg rest forward, foot pedals down, supporting patient's feet. This is what it should look like. When it's being stored, if I'm going to pull up on this seat, to store the wheelchair. See how the leg rests are forward? Okay, leg rests are forward. The reason is if I just have these leg rests, if I just have these leg rests loose like this, when I'm moving this thing, those leg rests will fly and I can risk hurting somebody. So you want these leg rests locked in place so they don't move when you're moving the wheelchair. And then during transfers, everything out of the way. Good. I know 2 years ago, they had this on the state exam asking your getting ready to transfer a patient into a wheelchair, how should the wheelchair look? Get those leg rests and foot pedals out
So
of the
they
way.
ask you?
It was multiple choice. It would give you 4 pictures. So let's talk about your role. This is so sad. I feel so bad for this lady. So this happened in Georgia. There was a reception person, like people that check you in the radiology department. A patient came in to have some x-rays done. So she got the older lady, she got her x-rays done. Her daughter went out to get the car and pull it up out front. Patient's in a wheelchair. And because she was weak and I guess had an injury or something. I don't know why she was there to get the x-ray. And they called for a transporter. And they waited. The daughter's got the car up front at the door and they're waiting and transporting, the transporter isn't coming. So the receptionist thinks to herself, well, I can do this. I can help because the daughter's waiting, blocking traffic. So she took the patient out to the car in the wheelchair. This is a receptionist. She had not been trained on wheelchairs, but she thought to herself, how hard can this be? I mean, it's a wheelchair. She brought the wheelchair up to the car and then helped the patient out of the wheelchair. She did not move the foot pedals or the leg rests. So all this stuff was in the way. She did not lock the wheelchair. And when she tried to get that wheelchair, or tried to get the patient up out of the wheelchair rolled. The patient got all tangled up in those foot pedals and leg rests and ended up falling. And she broke her leg. Did she get to go home?
No.
Nope. Now, the receptionist got in trouble. She was just trying to do a good deed. But she got in trouble. Why did she get in trouble? Say it loud.
She wasn't trained for that.
She wasn't trained for it. Even though it was something that she thought she could handle, it's just a wheelchair. We all know what wheelchairs are and how they work and what they do. She wasn't trained for it. So do you remember way back on day 1, I told you that CNAs do normal, routine tasks that you have been trained to do on stable patients. If you haven't been trained on it, no matter how much you might think you know, there's always something that you don't know. And what you don't know is what is going to hurt the patient. Does that make sense? Yeah, that resulted in a lawsuit. And this facility paid big bucks for this. All right, so when we are going to transfer a patient, we want to get those foot pedals up and those leg rests moved out. So we've got a wide open space there to transfer the patient into. Now we are going to pivot the patient around to sit them on the side of the bed. The way that we do this is not nearly as hard as you think. And you can actually pivot somebody way bigger than you. You just don't know it yet. It's all about the right preparation. Just like turning a patient, it's all about that right preparation. If I'm going to get this patient sitting on the side of the bed, this arm is going to go underneath her shoulders as far as I can get it. In fact, her furthest shoulder should be in this palm, not just a little bit under her back, all the way under. This arm's going to go over the knees. This is what everybody tries to do, is under. This doesn't work because now I'm having to push and pull at the same time. When you do this, it's just a pivot. Again, sit on the side of the bed. Good.
Mhm.
So it's not under and under. It's under and over. Once you get them sitting on the side of the bed, we're going to put their shoes on. Make sure their feet are flat on the floor. Get the gait belt on, and then get the wheelchair position. Remember I said it's got to be close? This is even still a little too far away. I should only be able to fit a piece of paper between that wheelchair and that patient. Nothing else. Super close. We're going to lock those wheels before we transfer that patient. We're going to make sure the gait belt is secure. We're going to stand with 1 foot in front of their feet, 1 foot beside their feet. We're going to ask them to put their hands on our shoulders. We're going to grab the gait belt, and on the count of 3, we're going to lift. When we get them positioned over the wheelchair, we'll make sure they can feel it before we have them sit. Position the feet on the foot pedals. We're going to take the gait belt off. Check their body position. Turn them so they're not facing the wall. And lock the wheelchair. It doesn't matter when you take the gait belt off, before you turn them, after you turn them, nobody cares.
And you don't have to lock it if they're able to move, correct?
You always lock the wheelchair. If they're able to move, they'll unlock it.
Okay.
We lock it.
Okay.
We lock it. And then we'll do the steps of the closing. Any questions? All right, I am going to show you this video because it's got good close-ups of these parts of it, but this is the older video. I don't have the new one done yet. In the older video, I pick him up, swing him around, and just set him down in the wheelchair. Remember that we have to make sure that he can feel that wheelchair behind him. So you don't hear me say it in the video, but can you feel that wheelchair behind you?
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good. How are you?
Wonderful. I need to get you up and into a wheelchair. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get your supplies, and I'll be right back.
Okay.
Okay, Mr. Jones, I'm going to pivot you around so you're sitting on the edge of the bed. I'll need you to scoot toward me first, if you would, please. Okay, and I'm going to ask you to cross your arms over your chest. I'm going to put one arm behind your shoulders, maintain a wide stance, and put the other arm over your knee. And on the count of 3, I'm going to pivot you. Ready? 1, 2, 3. Are you comfortable?
Yes.
Okay, can you sit up straight for me, please?
Yes.
Are you dizzy at all?
No.
Okay. I'm going to assist you in putting your shoes on. Are your feet securely in your shoes?
Yes.
And are your feet flat on the floor?
Yes.
Okay, let me get a gait belt. I'm going to place this gait belt around your waist, and this is going to help me lift you and pivot you into the wheelchair, okay?
Okay.
I'm going to place this around your waist. Go ahead and raise your arms, and then you can relax. We'll make sure that there's 4 fingers between the gait belt and the patient, and then lock it into place in the second guard. Let me get the wheelchair. I'm going to position the wheelchair next to the bed so it's at a slight angle, almost touching the patient. And we'll lock it into place. Okay, Mr. Jones, can you bring your feet together and slightly back? Thank you. I'm going to ask you to put your hands on my shoulders. On the count of 3, I'm going to lift you, pivot, and sit you down in the wheelchair, okay?
Okay.
Go ahead and put your hands up here. And on the count of 3, 1, 2, 3. Thank you very much. Are you comfortable?
Yes.
Okay, I'm going to remove the gait belt. Can you lift your arm, please? Thank you. Okay, I'm going to unlock the wheelchair and swing you around. Okay, Mr. Jones, I'm going to lock the wheelchair in place. And then I'll position the leg rests and foot pedals to support your legs. I'm going to lift your foot. I'm going to lift your foot. There you go. Okay, Mr. Jones, here's your call light. If you should need anything at all, please let me know. Are you comfortable?
Yes.
Can I get you any reading material?
No, thank you.
Okay, I'm going to open your privacy curtain and wash my hands. Thank you.
Thank you.
After washing my hands, I'll think about all the steps of my skill, make any corrections, and tell the evaluator my skill is done. Let me get Yeah, we don't have much room back here today. Okay, any questions on that one? Any questions on that one? Wherever I can reach. The further around the back I can get, the better it is for leverage. Because most of our weight is toward the back. So for leverage, I want to get, right back here is like ideal. But if I've got somebody that's very wide around, I may not be able to get my arms all the way around. So then it would be toward the side. Don't grab in the front. That's the one thing they don't want to see. Don't pull somebody up from the front. Okay, good. Let's go ahead and take your break. Come back in 15 minutes and we've got a couple more skills to do.
No, I need him. Okay, right. You walk me through it. But the guy was like, I just didn't. I was like, what?
Of course, I
You
know
missed
somebody
my
gonna train
episode?
me the
You
first day,
missed.
like,
You told me
walk
you
through
missed.
what
You
I would
failed.
have to do.
You taught me like, if you're they give me another episode. Like, you need two, one failed. So then I have to, where you get the headache.
Okay.
Are you like, damn,
And we're back.
Don't go to.
All right, so the next skill that we're going to learn how to do today is feeding a resident in a chair. I think all of you are well qualified to feed another human. Doesn't take a whole lot of additional training to be able to feed another human. You do need to understand, though, that diets matter. We have to make sure we're giving the right person the right meal because that will affect their overall health. But there are a few things that we do need to go over when it comes to feeding because this is a skill that doesn't really follow our rules. It's kind of a rule breaker, and I want to go over each one of these things as we go. So if you're looking at page 108, you can see all the principles down here that are involved. They're all spelled out here for you. Down here is test-specific information. Somebody with your level of experience should be able to do this skill in 9 minutes or less. It'll be another live testing student, which means you might be fed for the exam. That person will be sitting in a chair. Charting is required for this skill. If you look on page 109, you can see the care plan at the top of the page. The care plan says, feed a resident a snack. That's important. Feed a resident a snack who is unable to feed him or herself. The resident is sitting in a chair in an inappropriate position for eating. I don't care what your eyes tell you, this patient is not in an appropriate position for eating. So for the exam, we have to tell them, can you please sit up straight? Our care plan said they're not appropriate, so we have to address it. Good? Good? All right, it says that document intake on a food and fluid intake form, which you can see here. This is the food and fluid intake form. A big version of it is going to be located on page 169 of your book if you wanted a big version. Down here, you've got all of the supplies that you need for this particular skill. But this skill doesn't follow our normal rules.
You said 169? Sorry.
169. It does not follow our rules. This skill doesn't require a barrier. And that's because our food tray is our barrier. So we don't need a chucks or anything else. This skill's a little different because we don't close the privacy curtain. Eating is a social event. People gather in groups to eat. You usually have conversations during meals. Think of all the major events in your life. They usually revolve around food. Baby showers, weddings, funerals. They all revolve around food. Birthday parties, graduations, even backyard barbecues. So isolating a patient by pulling that curtain will actually cause them to eat less. We want to encourage appetite, not diminish it. So don't close the privacy curtain for this skill. You actually have to sit for this skill. It's the only skill that requires you pull up a chair to sit because you need to be on an even keel with your patient. There's a power dynamic here, guys. If you're standing over somebody, feeding them, it's a superior, inferior position. Patients tend to react to that subconsciously and they will not eat very well. They also feel rushed. So you have to pull up a chair and you have to have a conversation. It's the only skill where you have to have a conversation. The rest of the skills, we're pretty much just telling them what we're doing. You know, we're talking to them, but it's telling them what. Imagine for a second that I'm having to feed you. And I say, okay, I'm going to put the spoon in the cup and get a half spoonful. And we're going to bring it up to your mouth. I mean, that's so demeaning.
Yeah.
That's just not what we're doing here. We want to have a conversation. Doesn't have to be real for the test. You can make something up. Make something up.
Have you seen the game today?
Sure. Yeah. Did you see the game last night? You know, they've got kids coming in this afternoon for an Easter egg hunt, or they're showing a movie on the big screen. I mean, you've got just make something up. But in a clinical setting, you need to have something, a conversation starter that you can. My favorite conversation starter. What's the most exciting place you've ever been? That's a great conversation starter because most people have been more than one place in their life. So it gives us a couple of opportunities. But sometimes your patients will surprise you. I was caring for a patient up in Citrus County. This is when I was doing home care. She was in an assisted living facility and she was in her late 90s. This is 25 years ago, but she was in her late 90s. And I was doing wound care on her legs, and these wounds were very extensive. I mean, this is like a half-hour project. So I pull up a stool, start unwrapping the legs, and I know I'm going to be there a while, so I'm going to have a conversation. So I ask her, what's the most exciting place you've ever been? She sighs and says, oh, honey, I've never been anywhere. Okay, we're in Citrus County. I said, you've never been anywhere? Never left the county? And I'm joking. She's like, actually, no, I've never left the county. Wait, what? You have been in Citrus County your whole life and you never went to Ocala? You never left the county? And she says, well, it's not entirely true. I was born in Brooksville, but I don't remember that. The only time that she had not been in Citrus County is when she was born. Now, this is living history, people. This is somebody who has been in Citrus County for over 90 years. Never left. She knew everything about the county. When the roads were paved, when the first car dealership came in, all of the family gossip. I mean, it was one of the most interesting conversations I had ever had. And it was with someone who didn't think she had anything to contribute. But it's living history. Take a look around the walls. People will display things they're willing to talk about. For instance, I don't think I have it in this office. I had a picture of myself and my husband on a cruise ship. That is something I am willing to talk about. I will talk about cruising all day long. Now, I'm not going to pull out my deepest, darkest secrets and put them up because that's not something I'm willing to talk about. So you can look around and see if there's child drawings. Wow, who drew that? If there's pictures, talk about the pictures. If there's a statue, talk about that. Use the patient's environment to come up with topics of conversation, but you do need to talk to them. They are people, not just patients. And people have a need to pass on their experiences. And this gives us a great way of doing that. Okay. For the test, our care plan tells us the patient is not in an appropriate position for eating. So we're going to ask them, can you please sit up for me? The tray will already be on the table at the beginning of the skill. It will have a single serve pudding or applesauce cup. That's what they use for the test, a single serve pudding or applesauce cup. It'll have a fork, a spoon, a napkin, and a cup of water on the tray. Should you use a fork for pudding or applesauce?
No.
They're looking to see if you're using the spoon. Guys, they can't get this any more simple. You
use a fork for yourself for it.
You want to make sure you're not feeding them too fast. Give them time to chew and swallow. And you only want to fill the spoon half full. Now, when you're the patient for this, you're going to get some very specific instructions from the evaluator. So let's say that you're a patient. You're picked to be a patient. She's going to do this skill on you. As the evaluator, I'm going to take you to the side and I'm going to tell you only take 4 bites. Then no matter what she says, just say you're done or you're finished, you're full or whatever. Only take 4 bites. So the patient is going to get instructions. They're also going to be told to slump or slouch, which is why their idea of slumping and slouching and yours might be a little different. That's why the care plan says they're not in an appropriate position for eating. So when you're feeding her, she's only going to take 4 bites, and then she's going to say she's done. Now, that's important for 3 reasons. Number 1, we have to offer a drink before we feed them and every 2 or 3 bites. So if we get all the way through bite 4 and you didn't offer a drink, it's fairly obvious. Okay. The second reason is for time. Remember, those evaluators want to be home. We don't need to watch you feed this whole thing. But the third reason is because if you're giving 4 bites, we can see pretty quickly how quickly you're feeding, how overloaded the spoon is. We get a sense of what's happening in the feeding within 4 bites. The first one you might be a little nervous with, so it's usually, the ones after that are really kind of judged. Does that make sense? Now, you're only feeding 4 half spoonfuls. That's it. So when we go to document, this is like a quarter of the pudding container. That's all they're eating. If you're the patient for this and you don't like pudding, can you choke down just a couple of bites? Try to make it work. Don't be difficult with this one. We're going to offer the patient a hand wipe before we feed them. We're going to offer them a hand wipe before we feed them. It doesn't say your patient's immobile. Don't read into it. This is part of eating ritual. Most people wash their hands before they eat. And if food starts to come down, chances are they're probably going to bring their hand up to their mouth to put the food back in. So you don't want dirty hands around a mouth during mealtime. So we're going to offer a hand wipe at the beginning of the skill. We're going to sit and face the patient. We're going to offer a drink before feeding and every 2 or 3 bites. The spoon should be less than half full. And you want to give them time to chew and swallow while you're feeding them. Have a conversation. Doesn't have to be real, but you have to have a conversation. At the end, when they say, I'm done, I'm finished, no more, I'm full, whatever it is they say, you have to provide 2 forms of encouragement. I'm going to give you 3. Pick 2. I always ask, are you sure you don't want just one more bite? Because you can get a lot further with patients by being nice and encouraging them. And when I turn up the charm, it's kind of hard to say no to me. So are you sure? Just one more for me? Just a little bit more, please? Most people will say, yeah, just one more. The second thing I'm going to do is offer something else. We've all had these days, guys. We have all had these days where you get something, you take a bite, and you're like, nope, not it. That is not what I was looking for. So maybe your patient's having that issue. Maybe they took a bite, but it's just not it. So offer something else. Can I get you something else from the kitchen? The third thing I do is remind them that food is available so they don't think they have to go hungry. Those 3 things help your patient feel like you're investing in them rather than they're a byproduct of what we're doing. Good? Makes
So we
sense?
need to offer something for the test too.
So yeah, you want to use 2 of those. It doesn't matter which 2, but are you sure you don't want just one more bite? Can I get you something else from the kitchen? And let me know if you get hungry later. There is food available. Just like mouth care and denture care, leave their mouth clean. And then you're going to do all the actions of the closing. So this is not a hard skill. They give us 11 minutes, or not, is it 9? I think it's 9 on this one. 9 minutes. They give you 9 minutes. You're giving 4 half spoonfuls. Just 4. I mean, it doesn't take 9 minutes to do this skill. Don't rush it. Because if you rush it, the patient will feel rushed and the evaluator will pick up on that. Take your time. You got 9 minutes. When it comes to documentation, this is the documentation we're going to use. Again, this is on page 169 of your book. It's going to ask us, are we feeding them a snack or a meal? What does our care plan say? snack that you only gave them 4 half spoonfuls. So that's like 25%. Now, liquid is something you're going to have to really kind of measure, though, because they might say, I'm good, don't need anything. But remember, they're testing as well, so they may be a little nervous. Nervous gives us dry mouth. So this person may drink that entire cup of water. We don't know. You're going to document whatever they drink. Okay, good. All right, so details matter. We're going to offer a hand wipe before feeding, offer a clothing protector. They don't have to use it. We are going to offer it. We're going to offer a drink before feeding and every 2 to 3 bites. We'll let them lead. Feed slow, spoon only half full, and no childlike feeding techniques. So, no planes, trains, or automobiles. Don't do that. All right, so now let's talk about the actual documentation process. For feeding, we generally use something called a quarter scale. And when we're using a quarter scale, we have to kind of pay attention to what we started with to figure out what we end with. So this is how a quarter scale is made up. 0 means they didn't touch it. They refused it. Didn't eat. 100% means clean plate club. They ate it all. Good job. 50% means half. They ate about half. It's not scientific. We're not counting grains of rice here. They ate about half. Now, the other 2, the 25 and the 75, are where people run into trouble. I mean, most people can see pretty quickly they didn't eat it all, they ate it all, right? Those are easy. Half is pretty easy, too. It looks about half. 25 and 75 are judgment calls. 25 means the patient picked at it. They ate a little bit. Not enough to give them credit for half. But they did try. 75% means they ate most of it. More than half, but not quite all. Okay, judgment calls. Good? Good? All right. So if you look at this, this is what we started with up here. A sandwich, some broccoli, and Jell-O. I don't think broccoli and a sandwich go together, but that's all right. So how much did this person eat? Yeah, it wasn't refused because that sandwich, really touched. Yeah. What do you guys think? Was it half?
No.
And it's not refused, so that leaves us with
Barely touched.
25%. What about this one?
It had
Roughly half. Yeah, roughly half. What about this one?
75.
75. And what about this one? 100.
That's more. I mean, that's everything.
It's almost everything. Yeah, we can give them credit. I don't think that broccoli stalks count. We can give them credit for 100. But do you see how some of these might be judgment calls, right? Right? So this is closer to 100% than it is to 75. So we're going to give them credit for 100. You wouldn't want to say 89%. 89% way too specific for what we've got going on here. Good. All right, so now we have to get to fluid intake, which is measured completely differently. We have a lesson for this called intake and output in your book. But fluid intake is actually measured. Where food intake is estimated, fluid intake is often measured. Now, sometimes your fluid will be estimated, same quarter scale, but most of the time, we're actually going to measure this stuff. So in healthcare, we use the metric system. mLs or cc's, same thing. mLs and cc's, same thing, 2 different names. Remember in healthcare, we have 2 names for everything. mLs and cc's, same thing. We use that rather than ounces. We don't use ounces. in healthcare. But a lot of the things that we look at are going to be measured in ounces. So for instance, that coffee cup right there, that coffee cup is 8 ounces. So if we know the coffee cup is an 8-ounce cup and the patient drank all of it, well, we can't write 8 ounces because we don't document in imperial system. We document in metric. So we would want to convert this from 8 ounces to cc's, and we would do that by multiplying it by 30. So 8 ounce times 30 cc's, 8 times 30 is, anybody know? 240. So 8 ounces would be 240.
So you times it by 30.
Times ounces by 30 to get cc's or mLs.
And if it was like the cup of water on the test, it'd be 8 ounces, correct?
They have to tell you how many ounces.
Okay. And we know 1 ounce is 30 cc's.
Right. So here's the thing. When you go to work, no matter where you go to work, part of your orientation is learning about the facility. So you're going to learn their policies and procedures. You're going to learn where to find things. You're going to learn proper clock in and clock out. You're going to learn all kinds of stuff about the facility. And that's all facility specific. One of the other things that you're going to learn, if they calculate and take an output, they're going to tell you our juice cups here are 6 ounces. Our coffee cups are 8 ounces. Our water cups are 8 ounces. You're going to learn what the cups that they use at that facility are measured. Good?
Mm-hmm.
Make sense?
Yeah.
Okay. But if it's a pre-packaged thing, it's already going to tell us. So if you look at, so if you look at this soda can here, at the bottom, it tells us that this is 12 fluid ounces. Now I could multiply that 12 by 30 and get 360, but right next to it, in parentheses, it has the amount of mLs, which here is 355 mLs. If I multiply to be 360, so this is more accurate. Now, if I drink this whole thing, I drank how many mLs? 355, which is what it's marked as. If you look at that water bottle right there next to you, look at the label of that. How many ounces?
16.9.
16.9. Next to it, in parentheses, how many mLs?
500.
500. So if you multiplied 16.9 out, you would get a different number than 500. So on prepackaged, it would be close. But on prepackaged things, we go by what the package says.
Right, like apple juice that's already like in a bottle.
Right. That's 4 ounces usually,
Okay.
and it'll be 120.
Like 2 of those be like 8 ounces.
Right. Good?
Yeah.
Make sense? Okay. So if you go to page 106, this is an activity in your book that helps you put all of this kind of into use. So it has you estimate food intake here, and then down here is where we're going to work with fluids. So if we have to convert 6 ounces of juice into mLs, how many mLs would that be? 180. Our milk carton actually tells us how many mLs. So how many? 240. And 12 ounces of coffee. That's a lot of coffee. Hope it's decaf. 360. So we've got 180, 240, and 360. That was the intake. Now, at the end of the shift, we have to add everything they drank up together to get our total for the shift. So can anybody add up 180, 240, and 360 and tell me what we get?
$780.
780. Now, those of you who used a calculator on the test, you will not be able to use calculator. You got to be able to do this by hand. you will get a math question on the test, just one, but you will get either conversion or total intake addition. You will get one of those two on the test.
I have a question. So for the test, since we can't use calculator, can we write on the paper to figure it out? or
So
does
the
it have to
test
be
is on the
digital?
computer.
Okay.
You won't have, it's not a paper test, but they will give you a dry erase board
Okay.
for scratch for notes.
Now, when we're
And
documenting on the scales, can we do it like that? We document.
for the test, if you go to page 169, we're just estimating. We're estimating the amount of fluid that they took in. So for the test, it's a quarter scale estimation.
Okay.
They're not making us add it up. That's for the written. Let's talk about page 132 real quick, though. These are common medical abbreviations that you're going to find in healthcare relevant to CNAs. There's a lot more medical abbreviations, but these are the ones that are relevant to CNAs. The ones that are highlighted in gray, you probably should know. There's an activity on page 133 that helps you put this stuff into practice. But I want you to pay attention to this one right here, the NPO. NPO means nothing by mouth. It's a lot. How does NPO mean nothing by mouth? It's abbreviated Latin. Most of these are abbreviated Latin. Don't try to make sense out of them in English. They're not going to make any sense to you. If you go up to the top there of the first column, you'll see PRN as needed. Again, that's abbreviated Latin. Doesn't make any sense in English. Stat means immediately. Again, abbreviated Latin. Doesn't make sense in English. BID is twice a day and TID is 3 times a day. How does that work? So let me explain this. B stands for bi. How many wheels does a bicycle have? 2. That term bicycle is Latin. Bi for 2, cycle for wheel. So the word bicycle we think is English. It's not. It's Latin.
So do you know?
So yes, I do. So B is for bi. That means it's 2 times a day. So T, what do you think T stands for?
3.
Right. It's tri or tricycle as 3 wheels. Q, all by itself, Q means every. Every. And it's, again, abbreviated Latin. It's quaque, or I know I'm butchering that, but it's abbreviated Latin, something like quaque. QD, if we know Q means every, and BID, the last one meant day. So QD would mean every day. QHS, oh no, that doesn't mean anything. HS is how bedtime is said in Latin, hour of sleep, or insomnia, hour of sleep. So QHS would be every bedtime. My question is, are adding fluid intake on food intake together to a good answer? No. No, fluid intake is different from food intake. They're 2 different things. So food intake is what the patient ate. That's going to be a percentage. Fluid intake will either be a percentage or a hard number that we have to add up. So do you guys understand that most of these are not English?
We learned this, correct?
You definitely need to know NPO. And you probably need to know these up here.
So frequency.
Yeah, frequencies. Because you're going to see these on care plans.
I'm gonna bring this.
But then you have stuff in here like OOB, out of bed. That is abbreviated English, which just really messes everybody up. Yeah, PPE, personal protective equipment. So some of these are abbreviated English, some are abbreviated Latin. Learn the ones that are shaded. Good? All right, so when you go to document, for the test for this skill, we're using this side. We're just going to estimate the amount of food and fluid the patient took in. But in a clinical setting, you would be documenting on an intake and output sheet, which is what you see here. Remember, anything that goes in is intake, anything that comes out is output. Don't get those two confused. We're going to talk about that on Monday. But remember, intake is what goes in, output is what comes out. Don't get those two confused. You don't want to say that this person had 240 cc of apple juice as output. How does that work? Good. I have a whole lesson on intake and output on page 107. All right, so let me show you this skill. I don't have anything to feed you. Yeah.
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. Would you like a snack?
Yes, please.
Okay, I'm going to go wash my hands, get my supplies, and I'll be right back. Can I ask you to sit up straight for me, please?
Okay.
Thank you. Okay, Mr. Jones, let me get you a hand wipe so that you can wipe your hands. Would you like to take that? Thank you very much. Let me dispose of this. Okay, can I offer you a clothing protector?
Yes, please.
I'll just place this on your chest. Okay, it looks like we have pudding. How does that sound?
Great.
Very good. Can I offer you a drink before we get started?
Please. Thank you.
You're welcome. Okay, are you ready?
Yes.
There you go. Do you have any plans for this afternoon?
No, I do not.
They're showing a movie on the big screen in the activity room. Would you like me to get more information on that for you?
Yes, please.
Okay. How does the pudding taste?
Delicious.
Very good. Ready for another?
Yes, please.
Okay. Can I offer you a drink? Would you like something to drink?
Yes, please.
All right. Ready for another bite?
Yes, please.
Okay. Ready for another bite?
I'm actually full.
Are you sure you wouldn't like just one more bite?
I'm okay, thank you.
Can I get you something else from the kitchen?
No, thank you.
Okay. Let me know if you get hungry later, and we'll get something to eat. We do have food available on the unit.
Thank you.
Going to take the napkin. There we go. I'll remove this clothing protector from you, and we're going to put this in dirty linen. I'm going to go take care of your tray. I'll be right back.
Okay, thank you.
Okay, I'm going to place the tray back on your table. Is there anything else I can get for you? A magazine, perhaps?
No, thank you.
Your call light is within reach. Please let me know if you should need anything. I'm going to go wash my hands and document.
Okay, thank you.
After washing my hands, I'm going to document the amount of food that this patient ate. Using my documentation form. I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right, I want to talk about this. Deanne she's sent us a couple of messages on this. She failed her fluid intake. So Deanne failed the skills exam, but somebody was transferring to a wheelchair and did not lock the wheels. And still the next message says that person passed. So there's a couple of issues that I want to talk about with this. First of all, when you fail the exam, you don't always know exactly what failed you. Okay. So unfortunately, this is her interpretation. She messed up, fluid or food and fluid intake documentation. And that's her idea of why she failed. Now, I don't know, that could be, but it could also be other issues as well. So keep that in mind, that you will get a printout like this, and it will tell you what deficiencies you had. But remember, these are written for the nurses, not for you. So when you see something on here, you may not always be able to decipher exactly what action you took or didn't take that violated this checkpoint. Please keep that in mind. Okay. Now, as far as not locking the wheelchair, I think that the evaluator probably missed something, because that should have been, graded very harshly. So is there a possibility that the evaluators may miss something because they're looking at the checklist rather than at the person demonstrating? Sure, it does happen. So it's hard for me to say. I don't like to speculate. I wasn't there. I wasn't grading. I don't know. All I can tell you is to make sure that you know what you need to do to pass the next time.
So for the skills part, they're going to give us multiple.
3 skills.
Okay.
3 skills. You have to, if you go to page 25 in your book.
Dang, I wanted one so bad. I was just thinking about that.
Yeah, on page 25 of your book, those are all the testing care plans. You're going to get, you're welcome. You are going to get one of these 11. So all 11 clipboards that you see on page 25, you will get one of those.
I thought I was getting all of it. I'm like, oh.
Yeah, you're going to get one.
Okay.
I will tell you, it's the one you dread. Always. It is the one you dread. Yeah. If you are, oh my gosh, I hope I don't get catheter care. I really don't want catheter care. Oh, I really don't want catheter care. I don't want catheter care. You know what you're going to get on the test? Catheter care. It happens. I don't know why. So me, I would be dreading like ambulate, range of motion. I'd be dreading.
So
Yeah.
is the catheter care done on a mannequin?
It is.
Okay.
It is. Yeah.
What if they don't have dentures?
Well, for the exam, if you, what page is Denture care on? Go to page 97. Let's read the care plan at the top of page 97.
A resident with dentures is sitting at an overbed table with the dentures in a denture cup. The resident's dentures need to be brushed with toothpaste, and the resident needs mouth care. The denture is stored in a denture cup. After cleaning, the resident is not able to provide own mouth or denture care.
Okay, so where are the dentures at the beginning of the skill?
Stored in a denture cup.
Where are the dentures going to be at the end of the skill?
Stored in a denture cup.
So does the person who's playing the patient ever have the dentures in their mouth?
No.
So it can be done by a real person. Good. See how important those care plans are? It's like trying to write a movie without a script. If you don't have a care plan, the movie's not going to go anywhere.
So when you walk
Question
in
as well.
there, are you going to say that you're going to do mouth care and catheter care at first?
We do each skill in the order listed, and you're going to do all of the first skill before you go to the next skill. and then you'll do all of the second skill before you go to the third. So that means, let's say, just for demonstration purposes, I'll get to Betty in just a second. Let's say that we get this care plan set. Okay, so this one is provide mouth care to a resident with teeth, measure and record respirations, and change position to support a sideline. These are the skills I have to do for the test. So I would go in and do my opening for mouth care. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do mouth care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies. I'll be right back. Wash my hands, get my supplies, get the head of the bed up, brush their teeth, clean up, and then I do my closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Bed is in a low position, environment's clean. Open the curtain, go wash my hands. Then I have to tell the evaluator my skill is done. Because I can make corrections all the way through that until I say my skill is done. I can't go on to skill 2 until I say my skill is done. They're not going to let me. So once I'm done with skill 1, then I'm going to, hi, Ms. Jones. My name is Patty. I'm your CNA today, and I'm here to get your vital signs. Is that okay? Remember, we don't tell them respirations. Is that okay? I'm going to close your curtain, wash my hands, get my supplies. I'll be right back. Do skill 2, do my closing, say my skill is done. Then I can go on to skill 3. Okay?
So you're gonna say it 6 times.
Yeah, you're going to do your opening 3 times and closing 3 times. Yep. You can say the skill any way you want to. You can say, I'm going to do mouth care. Or if you're nervous, you can read it. I am going to provide mouth care to a resident who has teeth. Is that okay? You can do that as well.
This is a 2-part.
Okay, so Betty asks, my question is, can you use the clothing protector to clean the patient's mouth when feeding the patient? Yes. As for me, I had a score of 98, 88, and 85, and I failed the skill test. So I didn't understand 2. It makes me unhappy to take the test again. Yeah. And Betty, I'm so sorry. I can't, unfortunately, with just numbers, I can't, there's no way for me to.
This is the predominance of the question, though.
But yeah, yes, you can use a clothing protector. If you've got a clothing protector over their chest, you can use that to clean them up. Absolutely. That's what I would use. Softer than a napkin. All right. Good? Moving on. Pericare. This is on page 153 of your book. Page 152 has the short version. But look at this. Almost every single skill or every single principle we've learned is in this skill. Just like partial bed bath. Remember, partial bed bath was our longest? This one is the second longest, 17 minutes. This takes a long time. Has a lot of steps involved. They're all spelled out for you here. Test specific information is down here, so you can see this is a mannequin skill. We're going to do this on a mannequin. Care plan at the top of page 153 tells us the female patient has been incontinent of urine and needs pericare. The pad under the resident is wet, but the hospital gown and bedding is dry. That's a miracle. It does not happen like that. When you're doing pericare, you're probably going to have to change the gown, maybe the sheets, change what's wet. But the test is giving us a break here. They just want us to clean the patient. They just want to see that we know how. Good? Make sense? Mm-hmm. Supplies are down here. You do have to learn your supplies. There's no way around it. You have to learn your supplies. Let's talk about incontinence. What is incontinence? This is a 5th grade review of your urinary system. And yes, you did learn all this in 5th grade. You just don't remember it. So you have 2 kidneys. Those kidneys filter blood, and they take out the trash, all the bad stuff. Your kidneys work 24 hours a day. They don't ever stop. They don't go to sleep when you do. Your kidneys are constantly working. no vacations. As the kidneys filter blood, they pull out the bad stuff and it produces urine. That urine drips down tubes called ureters into the bladder. So kidneys work 24 hours a day, pull out waste products. That waste product becomes urine that drips down tubes into the bladder. Now, at the base of the bladder is a valve. That valve is holding the bladder closed. And as long as that valve is holding the bladder closed, all those drips just kind of add up in there. And the bladder gets fuller and fuller and fuller and fuller as more drips go in. Eventually, your bladder gets full, rings a little bell in your brain, says, hey, find us a bathroom. You go to the bathroom, we open the valve, urine comes out. When you're empty, the valve closes, and you go about your life again for the next 6, 8, 10, 12 hours. Good? You guys understand how the system works? Kidneys work how often?
24 hours.
That's important. When you are incontinent, system still works. Kidneys still filter blood 24 hours a day, never stops. Still makes urine, never stops. Those strips still go down ureters, never stops. What is broken is the valve. Everything else is still working. It's the valve. That valve is not keeping the urine in the bladder. So where do those urine drips go? Out. Your patient who is incontinent is going to be wet all the time. Drip, 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 drip. If you've got a patient who is dry, 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 really, really wet, that is not an incontinent patient. That valve was working. That's why they stayed dry. What you have are incompetent staff members that aren't getting that patient up to the bathroom. These are staff members that are telling the patient, just go, I'll clean you up, it's easier. So when I have CNAs that work for me that tell me, oh yeah, I checked my residents, they're all dry. Okay, either number one, you didn't check your residents, or number two, I don't have incontinent residents. And you're not taking them to the bathroom. Either way, this is a problem for me, isn't it? And it's a CNA problem for me to solve. You guys understand that? If your patient isn't wet all the time, they are not incontinent. Now, this is such a big problem because it's easier for staff members. It's easier to put a patient in bed and say, just go when you need to. I'll get you cleaned up. It's easier for staff. Do you think that patient wants to pee themselves?
No.
That's a dignity issue. And this is such a big deal that when when the state comes in and does their annual surveys, it is such a big deal that we have to assess the patients when they come into a facility. So when this patient gets admitted to my facility, I have to do an assessment. I've got to write down whether they're incontinent or not. And then if they become incontinent during their stay, unless there's a really good medical reason for it, the facility is going to get fined $10,000 per occurrence because they know that this affects the patient's dignity and it's done for staff convenience. Isn't that horrible? We shouldn't be doing that to people.
What if you have one that that's not incontinent, but they don't know that they have to go to the bathroom and they just go to the bathroom anyways on their self?
So we should be.
How are we supposed to know?
We should be taking these patients to the bathroom as often as the care plan tells us to.
So the care plan is.
which is usually every 2 hours. Yeah. If you take somebody to the bathroom every 2 hours,
They
Shouldn't
won't
be
get wet
having
often.
incontinence.
they shouldn't be incontinent.
Okay.
Now, there are exceptions always. There's always exceptions, but that's the nurse's responsibility to assess the patient and to write those findings down. Why is this an exception? Not a CNA problem. Good. Make sense? Do you see how this can affect your patients?
Yeah.
So, patients that are incontinent are going to be always wet because it's the valve that's a problem. But the good news is this valve is a muscle. Now, what happens if I all of a sudden picked up a barbell and started doing bicep curls on a consistent basis, right? All of this arm flab would probably strengthen up, wouldn't it? Because I'm exercising a muscle. This is a muscle. So if we have an incontinent patient and we get them to the bathroom every 2 hours around the clock, we're exercising the muscle. And eventually it'll get stronger. And we can help an incontinent patient become continent again in some cases. Oh, yeah. Yeah, this is called a bowel and bladder retraining program. And almost every one of my care plans has patients going to the bathroom every 2 hours. Before meals, after meals, every 2 hours. And patients that are incontinent, it's every 2 hours around the clock. I'm not asking that valve to hold urine for 8 hours. That's not fair to that valve. It's just trying to get on its feet. So we're going to take that patient to the bathroom every 2 hours around the clock to exercise that valve. It only takes 3 to 5 days usually for bowel and bladder training to kick in.
Now, how do you deal with residents in the middle of the night?
We wake them up. Wake them up.
Even if they're crazy?
Well, the problem is we're going to have to wake them up anyway. I'm going to show you why. Okay. So I'm waking them up anyway. Whether we're going to the bathroom or not, we're waking them up every 2 hours. And I'm going to show you why. So everybody's familiar with babies. We put a diaper on a baby, put them in a crib, let them sleep all night, and it's fine. Wake up the next morning, change their diaper, they still have skin on their tushes. Babies are not like adults. Baby urine is very mild, very neutral, pH neutral. It's not acidic. And that's because babies are eating very mild foods, things that aren't acidic. The acid level of your urine is dependent on what you eat and drink. Now, as adults, we eat and drink acid all the time. It makes food good. So that acid gets excreted in our urine. So adult urine, very acidic. So what do you think is going to happen if we hold acid against the skin?
It's going to eat your skin.
Yeah, it eats the skin. It burns it. That's right. So with a baby, you can put a diaper on them, put them to bed, let them sleep all night, wake up the next morning, and they're fine because there's not much acid in the urine. Adults, you put an adult brief, we don't call them diapers. You put an adult brief on an adult and leave them in it for 8 hours, they'll have all kinds of skin issues. Yeah. Rashes, infections, all kinds of issues. So we can't leave an adult in an adult brief for a long time. So that means that we're waking them up every 2 hours around the clock.
They don't have a choice.
That's right, to clean that skin and change them into something dry.
I would be mad as an old person.
So yeah,
Well, I don't wanna
we're
be
still waking
wet,
them up
but
every 2
still.
hours. Yeah.
I don't want to be woke up, but I don't want to be wet either. But I
Right.
do not want to be woke up from my
So-
sleep.
So let's pretend you guys are all patients for a second. Okay. Yeah, you already
I
don't
don't
want to be
be
there.
here already.
And now you're incontinent.
Uh-huh.
So you're wet. And that's just going to make you irritable.
Uh-huh. Gotta
And now
rely
you got
on
me coming in your room every 2 hours around the clock, cleaning you up and waking you up. And it's just a mess, isn't it? Right? You're really grumpy. So what if I came in your room and I said, listen, Egypt?
Not Jay.
No,
That's-
okay. I'm sorry. So what if I came in and I said, Renaje, I want to start a new process with you. Okay, so I really want to get you to where you're not incontinent anymore. And since we're already here every 2 hours waking you up to clean you up and get you into a clean adult brief, let's take the time to get you to the bathroom. And in about 5 days or so, you probably will get more control over your bladder and you'll be wet less often. Is that something that you're willing to do for about 5 days? Maybe, 5-7 days just to maybe get control of that bladder again? All of us would be like, yeah, because otherwise I'm facing this for the rest of my life.
Right, 2 hours.
So am I willing to give up 5 days, 5 nights of sleep to make this happen? Absolutely. Make sense?
That's cool if we can do that.
That's why they're usually on my care plans.
You still have a patient that's hard to go.
Sure. Yeah. Everywhere.
Talk to your therapist every day.
Yeah. And but I kind of understand where they're coming from. And this is not what their life was supposed to be. They're supposed to be in an RV traveling in the Grand Canyon right now. They're not supposed to be here. Not in their minds anyway. So I get it. I do. And when patients understand that I get it, we seem to click a little better.
Every once in a while, you're going to have that resident that just does not care.
Sure. Yep. Absolutely. Absolutely. Yeah. If they refuse to wake up, what should we do? Helen, go to your nurse. Go to the nurse. And here's the thing. If I'm just changing them, I don't need them to wake up. I don't need their involvement. Sleep through it. No problem. But if I have to get them up to the bathroom, I need them awake because I'm not going to carry them, So if they're refusing to wake up to go to the bathroom, that's a nurse problem. Because remember, I'm the one, as the nurse, that had to go in and involve them in the bowel and bladder retraining. So that's my opportunity to go in and say, okay, listen, Renaje, we talked about this. We tried to get you up last night. You didn't want to wake up to go to the bathroom. We really got to do this for about 5 to 7 days to strengthen that. We can't have all that pressure pushing down on it. We're just not going to meet our goal. So what can we do to work together to get you to the best level of health that we can? That's my job as the nurse, to go in and work with the patient. But if I don't know that Bernage's not waking up at 2 a.m.
Well, if she say, can we do it every 3 hours? Can we do it every 3 hours?
So I'm going to look at that on a case-by-case basis as the nurse. Depends. It really does. I mean, how much is she drinking? How much is she urinating? It's all about pressure. It's all about pressure, right? If you got a lot of liquid in the bladder pushing down on that valve and the valve's not working all that well, it's just not going to hold. It's all about pressure. But, maybe we're giving her a sleeping pill at 9 o'clock at night. That's going to affect this. So as the nurse, it's up to me to work with the patient and dig a little deeper. That's why, as CNAs, we toss all problems back to the nurse. Let's talk a little bit about adult briefs. These are not the solution you are looking for. Adult briefs hold urine, much like a diaper does. The problem is they're plastic lined because you don't want that urine to leak out onto clothing or bedding or anything else. So they're plastic lined. Plastic is going to hold in body heat and block out light. So now we've got a warm, dark, moist, acidic environment, which is the ideal breeding environment for all things bad. So patients in adult briefs often end up with yeast infections, skin issues, urinary tract infections, rashes, all kinds of really bad things. This is not the solution we're looking for. Yes, we use them if an adult is incontinent and out of bed. We will use these, and we still have to clean them and change them every 2 hours around the clock. But there is a better way. If the patient is in bed, I don't like using adult briefs. If they're in bed, it is better to just have them on a pad. Then the urine gets pulled away from the skin. Light and air can circulate. And remember, room temperature always wins, so we don't have warm. We end up with less skin issues and less infections when the patient is open to air on a pad. Now, as the nurse, I have to work with the patient. So if I bring this up to a patient and explain to them, this is what I want to do, and the patient's like, absolutely not, I need undergarments on, no problem. We'll use the adult briefs, but we're going to go into it knowing that there's probably going to be some skin issues there. And the patient's going to know that to make the best decision for them. And as CNAs, you are going to give really good peri-care to get that skin nice and clean. And you're not going to skip every 2 hours around the clock. Good. How do we know which way your patient is going to be treated, with adult briefs or with an incontinence pad? How would we know which patient gets what? The care plan. Nope. Jake.
Oh,
Thank you.
thanks, Amazon.
I know. Bye-bye. All right, so let's think about that pad for a second. Remember, room temperature always wins. Room temperature is about 72, 75 degrees, right? Urine coming out of the body is about 101 degrees. Remember, our body temperature is 98.6, and urine is way up here in our furnace area, so it's a little warmer. 100, 101 degrees. So that 101 degree urine comes out and meets 75 degree air. It's going to cool down really quick. What is that pad going to feel like to the patient? Cold, wet, and slimy. If you were laying on that pad, what's the first thing you would want done? Change the pad. Change the pad. Get me on a dry pad, please. But now we got a wet butt on a clean pad, so we're going to clean the patient front and back and then change the pad again. Now, cleaning is pretty easy. We already know how to do this. Don't add soap to your basin. Use paper towel to turn the water on. It should feel warm, not hot, not cold, just warm. Patient should check that water too. We're not going to add soap to the basin. We're going to add it to the washcloth. We're going to use the leaves method because this is a wet body opening. We'll change that water if it gets cold or soapy. Whatever we wash, we rinse. Whatever we rinse, we dry. Good. We already know this. We know how to clean. So basins are no soap zones. Use a paper towel. We're going to check the water. Patient's going to check the water. Change it if it gets cold or soapy. Use the leaves method. Whatever we wash, we rinse. Whatever we rinse, we dry. We'll use the leaves method because this is the genitals and the anal area. Change that water out if it gets cold or soapy and keep your surfaces dry. Lotion is not used for this skill. So care plan one more time. Says female patient has been incontinent of urine and needs peri-care. Pad under the resident is wet, but the hospital gown and bedding is dry. So we're going to start out with our opening. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do peri-care. Is that okay? Close curtain, wash hands, get supplies. We'll put a barrier on the table. We'll go get our supplies, including gloves. But we're not going to put them on yet. We want to fill the basin up with water. We're going to let the patient check it too. Put a privacy blanket over the patient and pull the sheet down underneath. And then we're ready to apply our gloves. We're going to expose the patient, but only the area that we need to expose. You want to try to keep your exposure to a minimum. We'll change that chucks out. We already know how to do this. Clean rolls toward me, dirty rolls away. You know how to do this already. We're going to roll the blanket up to expose the patient, put a towel over their legs to minimize exposure. Wring that washcloth out thoroughly, apply soap, and we're going to use that leaves method to clean. So if I have the washcloth in my hand, remember it's just a square washcloth, fold it in half and in half again, and we're going to hold it so those free ends are at the top. Tuck the two side pieces in. We're going to hold her open just a little bit, not a lot, just a little bit, to get down the inside middle, and it's always one direction, top to bottom. We'll move away and fold that over. Now we're going to clean down the outside, top to bottom on one side, fold that over. Top to bottom on the other side, fold that over. Now this one's going to clean here between the leg and the groin, this little crease. We're going to go top to bottom down that crease, fold that over, and top to bottom down that crease. And then this gets put aside on our barrier. Don't put it back in the basin. Think about where it's been. So it'll be put aside on the barrier. Then I'm going to get a clean washcloth. Remember, only top to bottom, one direction. Then I'm going to get a clean washcloth, wring it out. We're going to hold it in that leaves method, and I'm going to hold her open and rinse down the center. Fold that over, down one side, fold that over, down the other side, fold that over, skin fold that over, and skin fold. Because whenever we wash, we rinse the exact same way. We'll set that aside on our barrier. And then I'm going to take the towel that's on her legs and dry, top to bottom. Front is now clean. Let's scoot her toward us. Remember, scoot and roll. Scoot her toward us. And we're going to turn her on her side. But we want to minimize exposure. So we're going to pull that blanket down over her so she's not exposed. Scoot, roll, and then we're going to clean the backside. So I'm going to take this the third washcloth, wring it out really well, apply soap, and we're going to use the leaves method. So I'm going to go from the anal opening up the center crease. We'll fold that over. We're going to clean one cheek, fold that over. Clean the other cheek, fold that over. And once more up the center crease, because that's where urine is going to run. It's like a riverbed. And we're going to set this aside on the barrier because it's been used. We're going to take washcloth number 4 that's in the basin, wring it out really well, because whatever we wash, we rinse the exact same way. So we're going to rinse up the middle, fold that over, one cheek, fold that over, the other cheek, fold that over, and once more up the middle. We'll set that aside on the barrier. Whatever we rinse, we dry. So we're going to use that towel from earlier and dry. Same direction. Now we've got a clean butt. So we're going to change that pad out one more time. So we end the skill with a clean butt on a clean pad for the next 2 hours. Are we wetting the rinsing towels to rinse? Yes. Yes. You have to wet it. That's the whole rinsing means with a wet towel. So yes, you would wet the washcloth.
So we just sit all 4 of the washcloths in the basin.
To begin with, and then you're going to take them out one at a time as we use them. Yep. So we'll change that chucks out. Now this is where I told you you're going to have some trouble because it has to do with gloves and privacy blanket. Where have all those washcloths been? Yeah, the very personal areas of the patient, right? Do you want to touch those without gloves?
No.
No. So we need gloves on to take care of all this stuff. She is covered in the center of the bed. She is fine. Leave her alone. While we have gloves on, we're going to take care of all this stuff. We're going to clean our basin and put it back in our drawer. We're going to get our environment cleaned up, and then we're going to take our gloves off. Good? Good. So we're going to dispose of our dirty linen. We're going to clean our basin and put it away, and then we can remove our gloves. And then the final step is to remove that privacy blanket and pull the sheet up. Now we can do our closing, wash our hands, and end the skill. Good. So this is a big skill, but you already know all of the parts to it. You already know all of the parts to do this. So it shouldn't be too intimidating for you yet. Until you start to practice.
Till
All right.
test day comes.
Okay, so let me show you this video. Jake's gonna turn it on for you. And then we're gonna have practice time. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to do pericare. Is that okay? Okay, let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'm going to start out with a barrier. This gives me a clean place to place my clean supplies. So I'll place the barrier on the overbed table. And now I'll start gathering my supplies. I'm going to need 2 chucks, 4 washcloths, a privacy blanket, a towel. I'll place these items on the overbed table. I'll need a basin and soap. And I'm going to need a set of gloves. Okay, Miss Jones, let me go fill the basin. I'll use a paper towel to turn the water on. I'll make sure it's warm, not hot, not cold, just warm. Miss Jones, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place my washcloths in the water. Okay, Miss Jones, I'm going to place this privacy blanket over you. This is going to help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket out, being careful not to shake it or snap it. And then I'm going to pull your sheet down to about your knees. Now I'll get my chucks ready for use. I'm going to unfold the chucks, hold it up lengthwise, and roll it toward me. And I'll repeat that with the second one. Clean rolls toward me, dirty rolls away. Now I'll get my gloves on. Okay, Miss Jones, in just a moment, I'm going to ask you to scoot toward me, and we're going to roll you onto your left side so I can change the chucks that's under you. I'll place one of the chucks on the bed. Miss Jones, can you scoot toward me, please? Thank you. And roll up on your left side. 1, 2, 3. I'm going to roll the dirty chucks toward the patient. Tuck it under her hip. Unroll the clean one and tuck it under the soiled. Miss Jones, can you roll back onto your back, please? Thank you. And scoot to the middle of the bed. Okay, I'll come around to the other side of the bed now. Miss Jones, can you scoot toward me, please? And roll up on your right side. 1, 2, 3. We'll remove the soiled chucks from the bed and unroll the clean one. This is going to be thrown away. Okay, Miss Jones, we're going to start cleaning now. I'm going to roll your blanket up to about your waist. This is going to expose you. Please let me know if you're uncomfortable in any way. So I'll roll the blanket up, And on the way, I'm going to try to get that gown rolled inside the blanket so that exposes only the peri area. I'll cover her upper legs with a towel. And then get my first washcloth. I'm going to wring this out. And soak 5 corners. 1, 2, 3, 4, 5. Okay, Miss Jones, I'm going to clean now. I'll use the heel of my hand at the top of her peri area and my index and middle finger to spread her slightly open so I can clean down the inside middle, top to bottom, and then we'll fold that leaf over. We're going to clean the outside labia, top to bottom, down one side, and fold that over. The third leaf will clean the other side of the labia, top to bottom, fold that leaf over. The fourth leaf is going to clean this area between the leg and the groin, this skin fold, top to bottom. We're going to fold that over, and we'll repeat it on this side, top to bottom. Now we'll place the washcloth back on the barrier. The second washcloth, we're going to wring out. And we're going to rinse all of those areas the same way we washed. So we're going to hold her slightly open to clean down the middle, top to bottom. Fold that over. We're going to rinse down one side of the labia, top to bottom. Fold that over. Rinse the other side of the labia, top to bottom. Fold that over. We're going to rinse the skin fold down one side, top to bottom. Fold that over. And the other skin fold, top to bottom. We'll set that aside. Now we're going to dry all of those areas using short, soft strokes or a gentle pat. I'm going to unroll the blanket, which will place her gown back over her legs. Okay, Mrs. Jones, I'm going to scoot you toward me now, and we're going to roll you onto your left side so I can clean your back side. Go ahead and scoot toward me, and we're going to roll you over onto your left side. 1, 2, 3. The evaluator will hold the mannequin in place for you to complete your cleaning of the patient's backside. Okay, I'm going to take the fourth washcloth, wring it out really well, and we're going to soak 4 corners. 1, 2, 3, 4. I'm going to start at the anal opening and go up the center crease, right up the middle, and we'll fold that leaf over. The second leaf will clean one buttocks. We're going to fold that over. The third leaf will clean the other side of the buttocks. We'll fold that leaf over. And the fourth leaf will clean from the anal opening up the center crease one last time. We're going to set that aside. Whatever we wash, we rinse. So I'll wring that out. And I'm going to rinse the same way we washed. So from the anal opening up the center crease, fold that over. One buttocks, fold that over. The other side of the buttocks, fold that over. And once more up the center crease. And then we'll dry all of those areas. Okay, Ms. Jones, I'm going to change that pad out from under you so you're on a nice clean pad. We'll roll the soiled chucks toward the patient and tuck it under her hip. Unroll the clean chucks and tuck it under the soiled. Ms. Jones, come on back, please. And scoot to the middle. Thank you. Okay, Ms. Jones, go ahead and scoot toward me. And roll up on your right side. 1, 2, 3. Thank you. We'll remove the soiled chucks from the bed and unroll the clean. Okay. Go ahead and scoot back to the middle, please. This is going to be thrown away. Okay, Ms. Jones, I need to put all of my soiled items away and clean my basin. I'll be back in just a moment to get you situated. These items will go in dirty linen. And the basin is going to be cleaned the same way we clean everything else. We'll dump the water into the sink. Rinse the basin. pick it up with a paper towel and dry the inside. We'll discard that paper towel. We'll dry the outside and discard that paper towel. And then we'll get it to soak. I'll use the paper towel to open the drawer and store the basin back inside. These paper towels will now be thrown away. The barrier is going to be disposed of. And now I can remove my gloves. Okay, Ms. Jones, I'm now going to gather the privacy blanket up and pull your sheet back up. So I'll collect the privacy blanket by lifting from the bottom or underside of the blanket. I'm going to pull the sheet up and ball the blanket up into a ball. That way no trailing edges will contaminate other surfaces. Okay, Ms. Jones, let me go put this in dirty linen. Are you comfortable? Is there anything else I can get for you while I'm here, like a magazine? Okay, here's your call light. If you should need anything at all, please let me know. I'm going to go open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then let the evaluator know my skill is done. All right. So we got a question. Betty asks, can you make the patient lift their feet up to clean the side of the patient's legs? Sure. I don't know. I mean, every patient's going to have a different level of ability. So, you kind of have to look at each one of these individually. If you have a question about the patient's level of ability, you would ask the nurse responsible for that patient. So I hope that helps. Okay, you can go ahead and take that down. All right, so over the weekend, you have chapters 8 and 9. Remember, 8 is on nutrition. 9 is going to be on rehabilitation. And nope, that's not you. And then you guys got your review sheets as well. Does anybody have any questions for me? Any questions?
I did not get class 6. I got class 7.
Oh, I handed out the wrong ones, didn't I?
Oh.
We're going to hang on to class 7, I guess.
Yeah, that'll be for the next class. Monday's class. So on Monday, we have the last 3 skills. We're down to the last 3. That's it. 3 or 4. It might be 4. Let me take a look. 3. Yep, last 3 skills. So we're going to learn how to assist somebody with a bedpan. We're going to learn catheter care, which is peri care with an extra step. And we're going to learn how to empty the drainage bag. You'll have about an hour and a half to 2 hours of practice time on Monday because I don't have much to teach you on Monday, right? So just like today, this last skill was a combination of everything that we've learned before just applied to a different body part. So that's what we're going to end up with on Monday as well. So we're on the easy part from here on out. So the rest of the class today is going to be practice. You guys are free to stay and practice. The mannequin is here. The supplies are here. You've got your book with all of the step-by-step instructions. Those of you who do need to leave, you are welcome to leave. Just remember, if you're not practicing here, you want to make sure you're practicing somewhere. Those of you that are joining us live, thank you so much for tuning in. We truly appreciate it. Please remember, Tuesday is our next game show. So feel free to join us for that. And we will see you on Monday at 9 a.m. for class 7. Until then, happy caregiving. Bye.